this. So I have my presentation about balloon deflection technique to facilitate the stent delivery in impassable situation during PCI. Are my slides clearly visible? Hello.
Yes, we have your voice.
Yeah, my slides are clearly visible.
Yes, yes, it's
Yeah.
clear.
Okay, thank you very much. So let us start. Sorry. Yeah, about this study. So why we conducted this study? Uh, uh, we all must have faced those who are interventional cardiologists. They must have faced the difficulty in long and multiple lesions in the background of tortuous and tortuous coronary artery, which often require multiple stents that we are not able to pass the stents, especially which are calcified. The entry and passage of another stent through an already deployed stent becomes challenging because of poorly expanded stent struts, calcified tissue, or underlying tortuosity, highly angulated takeoff of the vessel, and lack of coaxiality. So to tackle all of these difficulties, we have in our armamentarium the mother in child catheter system, what we call guidezilla or guideliner. We also use body wire, which gives us extra stability, or sometimes we go for deeper intubation of the guide catheter, especially in the RCA. And many a times we do the balloon anchoring to bail out of these situations. It can also be facilitated. That means the stent can also be facilitated by the balloon deflection technique, where balloon at the proximal edge of the main stent over a body wire help us to deflect second stent either digitally or in a side branch by blocking the potential dead. So we conducted this study to see the practicality, efficacy, and safety of a balloon deflection technique. So coming directly to the methods, it was actually a retrospective. We have been using these techniques over a few years. We have done around 37, used this technique in 37 patients. It was a single center study. Out of 16,189 patients who underwent PCI from January 2014 to August to December 2019 at our medical college who are included in this. Out of those, only 37 patients underwent this technique. Balloon deflection technique was used when the stent could not be delivered to the target lesion. That means the side branch in case of bifurcation, either proximally or digitally, due to various technical challenges, such as the origin of the vessel having an highly angulated takeoff. For example, the OM1 in LCX, or sometimes the proximal tortuosity of the vessel, that where we want to deploy the stent digitally, but there is proximal tortuosity. Third, in some cases where there is calcification. So what is this balloon deflection technique? Actually, we use another wire, workhorse wire, which is parked in another vessel where we do not plan to deploy the stent, but we use that wire for gaining access so that we can put a balloon over there. And I can show you diagrammatically in next slide. It will be easy to comprehend that. So a 0.14-inch workhorse wire was parked in the distal part of the target vessel as a buddy wire besides the workhorse wire in the target vessel. On this buddy wire, the deflection balloon, whose diameter was decided according to the diameter of the proximal vessel, in the case of first stent, was parked at the site of resistance. The balloon was not inflated, but kept in that way that it was partly inside the stent and partly outside. The length of the balloon was kept more than 12 mm to ease the delivery of the stent. So this is the diagrammatic presentation. It was easy to comprehend. For example, just like this is a bifurcation and we have, for example, take this as an LCX. So we have put a stent in the proximal part. Now we want to tackle the side branch. Many a times we must have seen that we face difficulty of taking the stent, which is colored in the red, towards the more angulated branch. Or sometimes even if the stent is not there, the calcification or tortuosity is there. So we can keep in mind that any hurdle and the proximal part can be tackled by this. So as you can see the diagram B, the balloon has been put at the proximal edge, and with keeping balloon in the proximal edge, the stent, which is colored red, can be easily deflected towards the side branch, which is our target. So the safety endpoint was defined as the absence of periprocedural complication by perforation, dissection, and stent dislodgement. Coming directly to the results, the baseline character of these 37 patients, they were elderly, 75, and mostly male, 75%, and 32% patients had hypertension, 27% had diabetes mellitus. The indication for PCI mostly was this chronic coronary syndrome. They had stable angina, and 25% 25% had NSTMI. 25% had NSTMI. So let us look at the results. So first of all, our success rate out of those 37 patients, we were able to tackle, we were able to deploy the stent across the difficulty, whether it is calcification or it is tortuosity or it is because of the program stent in 36 out of the 37. That means the success rate was 97.3%. So the lesion characteristic where we encountered the difficulty mostly was because of the tortuosity, 24%, and the angulation was in 27%, and the calcification was in 18%. Mostly our patients, they had type B2 lesions for around 50% of the patients. The mean diameter of the stent which were deployed was 3.3, and the length of the stent was 18 mm. That means they were large stents. The deflection balloon used was around 3 mm in diameter, and the length was 20 mm. That is what I said, that we do not need, we usually need longer balloons so that the stents can track over them easily, or I will say glide over them easily. The lesion preparation was aggressive predilatation was used in all patients. Cutting balloon was used in 20% of the patients. And the complication, we suffered only one complication, that distal dissection happened in one patient. This is not 3.7, this is 2.7%. There was no mortality. The success implantation was successful in 36 out of 37 with success rate of 97. As I already said, in one case, stent could not be delivered using the balloon deflection technique. Stent was finally delivered using Guidezilla Maiden child catheter. Overall failure was 2.7, which were contributed by extreme tortuosity, angulation, and severe calcification. The conclusion is the balloon deflection technique may provide a simple, convenient, and inexpensive solution without further need of additional hardware except a body wire and a balloon. Thank you very much for the first presentation, and I will present my second presentation. It is about non-alcoholic fatty liver disease as an independent risk factor for carotid atherosclerosis. So the background of this study is non-alcoholic fatty liver disease is a frequently encountered clinical condition in clinical practice, particularly in obese and diabetic. We all encounter such patients who have, we do an ultrasound, they have vague abdominal pain, and it comes out that they have grade 2, grade 3 fatty liver. Sometimes they have non-alcoholic steatohepatitis with raised liver enzymes. In general population, its prevalence ranges between 10 to 39%. Research studies have pointed out the association between non-alcoholic fatty liver disease and high cardiovascular risk. This association is independent of classical risk factors of liver enzymes or absence of metabolic syndrome, and is strongly correlated with non-alcoholic fatty liver disease. So carotid atherosclerosis is regarded as a surrogate of coronary atherosclerosis. The aim of the study was to study the correlation of carotid intimal thickness with different grades of fatty liver in North Indian population. This was a prospective study and included total of 200 cases and 100 age and sex measured controls. Non-alcoholic fatty liver disease was diagnosed on the basis of ultrasonography. Each patient was subjected to a battery of investigation, including complete hemogram, liver function test, lipid profile, hepatitis serology, and carotid ultrasonography. Three measurements of the intimal thickness were obtained from the right and left common carotid, proximal to the bifurcation with 1 centimeter interval. Largest value among the three measurements on each side were taken for calculating the mean. Intimal thickness was taken as mean of the left and right. The values of intima media thickness were taken as normal if it was between 0.6 and 0.8 mm, and it was thickened if it was more than 1 to 1.5 mm. We excluded the patients who had chronic liver disease, portal hypertension, chronic hepatitis B and C, any chronic debilitating disease, and we also excluded the patients with diabetes mellitus because we know that diabetes mellitus is itself a risk factor for coronary and carotid atherosclerosis. We only wanted to find the healthy patients who didn't have any other risk factors like diabetes, but who had non-alcoholic fatty liver disease. Do in them that fatty liver disease grading correlates with the intimal thickness or not. That is why we excluded the diabetic patients. So the base, coming directly to the results, baseline characteristic, the mean age was 42. It was comparable between the cases and controls. 42 years in the cases and 41 in the control. Around 43% were male, and this in cases, and 40% were male in the controls. So about the comorbidity, hypertension was present in 13% of cases and 10% of controls. Mean BMI, you can see they were not that much obese. So the level of liver enzymes in different grades of fatty liver. So we graded them into grade 1, grade 2, grade 3 on the basis of the ultrasound. We can see the the amount of liver enzymes keeps on going as we grow to the higher grade of fatty liver. That means those patients were not only hepatosteatosis, but non-alcoholic hepatitis. That means the liver damage has already started and the liver enzymes was raised, and it correlated to the grade of the fatty liver in them on the basis of the ultrasound. The carotid intimal thickness in cases, we can see in cases, it was zero point 0.8 on the control left intimomedial thickness. It was 0.8 mm in cases and controls 0.5. On the right, it was 0.8 and the controls was 0.57. And they were statistically significant differences. So now this is the main slide. I want to focus on this because we wanted to see the correlation of carotid intermedial thickness with different grades of fatty liver. So what we have done here, we have on the basis of this USG abdomen, we have graded into grade 1, grade 2, and grade 3 fatty liver. And we have separated left and right intermedial thickness. This is the right, this is the left, and in between we have the mean. So 200 patients of left with left carotid intermedial thickness and right. So we can see as we progress from grade 1 to grade 3, there is a gradual increase from 0.69 mm of the intermedial thickness to 0.9. The same happens in right sided of intermedial thickness. So our conclusion was there the level of carotid intermedial thickness was more in cases than in controls and progressively increased with the grade of the fatty liver, which was statistically significant. Now, if we say that the carotid intermedial thickness is increased in patients who have a higher grade of fatty liver, that in turn correlates that other vascular beds must have also been involved. So we can correlate as those patients who have non-alcoholic fatty liver disease with higher grades have higher chances of having carotid as well as coronary atherosclerosis. Thank you very much.
my paper entitled Trends in the Burden and the Determinants of Hypertensive Heart Disease in the Eastern Mediterranean Region, 1990 to 2019, an analysis of the global burden of disease study 2019. Hypertensive heart disease, of one of the end-organ damage of consequences of hypertension, is an important public health issue worldwide. Data on the hypertensive heart disease burden in the Eastern Mediterranean region are scarce. We aim to investigate the burden of hypertensive heart disease in the Eastern Mediterranean region, its member countries, and globally from 1990 to 2019. We used the 2019 global burden of disease or GBD data to report the hypertensive heart disease age standardized prevalence, disability, adjusted life years, years of life lost, and mortality, as well as hypertensive heart disease risk factors attribution percent with their 95% uncertainty interval. Global data are reported alongside Eastern Mediterranean region data and its 22 respective countries. We compared the burden of hypertensive heart disease by socio-demographic index, sex, age groups, and countries. Results. In this table, you can observe trend of prevalence of hypertensive heart disease at global and Eastern Mediterranean region and its member countries. In 2019, the lowest age standardized prevalence rate of hypertensive heart disease was in Saudi Arabia. That was a high middle socio-demographic index. Qatar, high SDI, and Syrian Arab Republic, middle SDI. By contrast, the highest hypertensive heart disease age standardized prevalence was in Jordan as a middle SDI country, Kuwait, and as a high SDI country, and Lebanon as a middle SDI country. The highest increase in age standardized prevalence of hypertensive heart disease during 1990 to 2019 was in Oman, about 21.4%, followed by Sudan, 10.28%. Inversely, Qatar and Bahrain had a considerable decrease during the same period, minus 9.75% and minus 8.27% respectively. This figure shows the prevalence trend, the trend of prevalence by gender. As you observed, the female age standardized hypertensive heart disease mortality prevalence was higher than males at Eastern Mediterranean region and the global levels. However, this difference was much greater in Eastern Mediterranean than globally. This table shows the change in mortality rate of hypertensive heart disease in this region and global. There was a decreasing trend in age-standardized hypertensive heart disease mortality rate between 1990 and 2019 at both the global and Eastern Mediterranean region levels. The age-standardized mortality rate of hypertensive heart disease in 2019 range from 4.3 per 100,000 in Saudi Arabia to 74.5 per 100,000 in Afghanistan. And this image shows the trend of mortality. As you see, the female age standardized hypertensive heart disease mortality rate was higher than the males at the Eastern Mediterranean region and the global levels. However, this difference was much greater in Eastern Mediterranean than globally. In this table, I indicate the rate of disability adjust life years at global level and Eastern Mediterranean region. The age standardized DALYs or disability adjust life years of hypertensive heart disease was approximately doubled in Eastern Mediterranean region compared to global levels at all study time points. However, there was a decline in both DALYs and years list life globally and in the Eastern Mediterranean region from 1990 to 2019. The highest rate of age standardized DALYs in 2019 was observed in Afghanistan, followed by Yemen and Somalia. On the other hand, Qatar, Saudi Arabia, and Bahrain had the lowest rate of age standardized DALYs in 2019. And the trend of DALYs at by gender at Eastern Mediterranean region and global is showed in this image as you see. We observed a decreasing trend in DALY from 1990 to 2019. In this image, I'm trying to show a relationship between HAQ and hypertensive heart disease mortality. HAQ is an index for health care access and quality index. As you can see, HAQ had increased in all Eastern Mediterranean countries during 1990 to 2015, except in Afghanistan. There was an inverse relationship between HAQ and hypertensive heart disease mortality as expected. So this is the first study on the epidemiology and trends of hypertensive heart disease burden, including prevalence, mortality, DALYs, and attributable risk in the Eastern Mediterranean region over 3 decades. The age standardized prevalent rate of hypertensive heart disease was higher in Eastern Mediterranean region as compared to the global level based on age and sex throughout the period between 1990 and 2019. This can be explained by the higher prevalence of hypertension in this region. Among the East Mediterranean region countries, Jordan had the highest prevalence of hypertensive heart disease. According to a study from Qadir et al., the lack of well-organized programs for prevention and intervention on hypertension and the high rate of obesity, physical inactivity, and intake of salt and fat in this country is responsible for this high level of prevalence. We observed an increasing trend in hypertensive heart disease prevalence from 1990 to 2019 at both the EMR and global levels. This can be justified partly by improvement in life expectancy, global population aging, and redefining of hypertension by 2017 American College of Cardiology and American Heart Association guideline. The prevalence of hypertensive heart disease in all 22 East Mediterranean region countries increases with age in both men and women. Considering the worldwide increase in the elderly population, it is very important to effectively prevent and manage hypertensive heart disease for older patients. Sex-based results showed that the standardized hypertensive heart disease mortality and daily rates in females were higher than males in the East Mediterranean region. This difference was much greater for the EMR than global level. Additionally, in the majority of East Mediterranean countries, the prevalence percentage of hypertensive heart disease between 1919 and 2019 was higher in females than males. Liu and Lan associated this difference to the role of sex hormones in cardiac metabolism and cardiovascular biofunction in hypertensive heart disease development. Given hypertensive heart disease mostly occurs in older age, women undergoing menopause would be more vulnerable due to losing protective effects of their hormones against high blood pressure. The burden of hypertensive heart disease varied widely across the countries in EMR. As mentioned in the method section, socio-demographic index extensively varies between various countries in East Mediterranean region. Regarding hypertensive heart disease prevalence, we witnessed higher proportions in countries with more desirable socio-demographic index. Conversely, these countries had lower mortality and daily from hypertensive heart disease compared with low, middle, and low socio-demographic index countries. It can be explained by more access to diagnostic and therapeutic services, higher literacy, more optimal health financing, and higher country capacity in high SDI countries in the Mediterranean region. Finally, it should be noted that there are other factors linked to hypertensive heart disease in the EMR countries, which should be considered when interpreting hypertensive heart disease profile. The East Mediterranean region has extreme diversity in development, wealth, and health that can influence its diversities in disease rates, including hypertensive heart disease. For instance, the region has considerable heterogeneity with respect to characteristics such as historical background, geographical, geopolitical, and social context, ethnicity, and language spoken, gross domestic product, socio-demographic profiles, health indicators, and health system capacity and coverage. Thank you for your attention. And
and pattern of CAM among patients with cardiovascular disease, what are their potential benefits, risk, mechanism, and evidence of CAM therapies for the prevention and treatment of cardiovascular diseases. How do patients and healthcare providers communicate and collaborate about CAM use for cardiovascular disorders? What are ethical, legal, and regulatory issues and challenges of CAM use for cardiovascular disorders? And how can be integrated and optimized with conventional medicine for the management of cardiovascular disorders? So these are some aims and objective of my presentation to explore the prevalence pattern and reasons, some outcomes of CAM among patients with chronic diseases, to include some systemic reviews and meta-analysis of existing literature on this use of CAM in these chronic illnesses, then provide some recommendation implication for healthcare provider, policymakers, researchers, and patients regarding the integration, regulation, education, and communication of CAM in chronic disease management. And finally, to identify the most common types, sources, modalities of CAM used by the patient with chronic diseases, and to compare their differences and similarities across different region, culture, and health system. So for now, first we have to know about the definition of CAM. What is CAM? That is abbreviated as complementary and alternative medicine. It's a group of diverse medical and healthcare system practices and products that are not generally considered as a part of conventional medicine. So it is actually being used along with or instead of conventional medicine, depending upon the preference and needs of the patient. So it is encompassing a broad spectrum of healthcare practices and therapies. So we all are well aware of this conventional treatment, like it is involving medications, lifestyle modification, revascularization therapies have, as it has been discussed previously, like PCIs or angiography, and cardiac medications, cardiac rehabilitation, implantable devices, anticoagulant therapies, heart failure management. And there are some limitation of these traditional or conventional therapies, like for example they produce some adverse effect and side effects, individual variability in response, patient is showing non-compliance, there is limited curative approaches, and invasive procedure like PCI, angiography, and cabbage, and there is also some percentage of mortality risk as well. So cost is very high, limited option for some condition, like they don't have any suitable medicines, or like patient cannot undergo the surgical process. Sometimes they show chronic nature of cardiovascular conditions, and sometimes these conventional medication shows medication interaction. So now we are going to categorize the complementary and alternative medicines into primary categories. So these are mind body practices, manipulative and body based practices, energy therapies, biological based practices, whole medical systems, mind body medicine, cultural practices, and indigenous medicines. So what is scientifically significance of this CAM? So CAM may be based on historical or cultural traditions such as Ayurvedic medicine and traditional Chinese medicine, on scientific research such as biofeed and hypnosis, or on personal beliefs such as prayers and meditation. CAM may also involve natural products such as herbs, vitamins, dietary supplements, physical methods such as massage, acupuncture, chiropractic, and mind body interventions such as art therapies, music therapy, and therapeutic touch. I can remember one example of CAM, complementary and alternative medicine. Like I checked blood pressure of a old lady, like she was 80 plus, and her BP was 190 by 110. And like his son gave him some drops of homeopathic medicines, and I checked her blood pressure after 15 to 20 minutes, and it was dropped up to 140 by 90. So I was amazed and shocked to see this, like this homeopathic drug is working. Benefits of CAM: improving quality of life and well being by reducing pain, nausea, fatigue, anxiety, and depression, enhancing the immune system and body's ability to heal itself, provide a sense of control and empowerment over one's health, offering a holistic view of health that considers the mind, body, and the spirit, respecting the individual's preferences, values, and beliefs. So, here are some approaches: mind body techniques, herbal and nutritional supplements, acupuncture and traditional Chinese medicine, TCM, mindfulness based stress reduction, MBSR, chiropractic care, aromatherapy, and cohort breathing. We'll discuss them. So, first one is mind body technique. So, these are practices that aim to enhance the positive impact of mind on the body. It can also provide a sense of control, empowerment, and holistic view of health that respect the individual preferences, values, and belief. Some examples are meditation, yoga, acupuncture, biofeedback, and hypnosis. So next, herbal supplements, herbal and nutritional supplements. So these are products that contain natural ingredients such as herbs, vitamins, minerals, amino acid, or other substances. Some example of herbal and nutritional supplements are echinacea, ginseng, vitamin D, omega-3, B complex. Acupuncture and traditional Chinese medicine, TCM. These are two related but distinct forms of medical practice that originated in the China and have been used for the thousands of years to treat various health problems. Some examples of acupuncture and traditional Chinese medicine are acupuncture, Chinese herbs, cupping, dermal friction, and moxibustion. Next one is MBSR, mindfulness based stress reduction. It's a program that teaches how to use mindfulness in daily life to cope with stress, pain, and illness. Sorry. Mindfulness is a practice of paying attention to the present moment with curiosity and openness without judging or reacting. So, some example of MBSR are body scan meditation, mindful eating, mindful movement, sitting meditation. Like when you're doing something, you are meditating, and your each and every act is purposeful. So, it is helpful in relieving pain or stress. Next one is chiropractic care, like it is common in Pakistan, India. So it's a form of complementary medicine that involves the diagnosis and treatment of disorder of musculoskeletal system, especially the spine, using manual techniques such as spinal manipulation, joint mobilization, and soft tissue therapy. Some examples of chiropractic care are Thompson drop table technique, Gonstead adjustment, spinal mobilization, and soft tissue therapy. Next one is the aromatherapy. So aroma, you mean aroma smell. It's a kind of perfume. So it's a type of complementary medicine that uses natural plant extract, also known as essential oil, to promote health and well-being. Some example of aromatherapy are diffusing lavender oil in the air to relieve stress and improve sleep quality. Second example is massaging rose oil into skin to enhance mood and reduce anxiety. Next one is spraying orange or bergamot oil in the room to reduce depression and improve skin condition. So next one is coherent breathing. So it's a form of breath work that focuses on reducing the amount of breath per minute. So we know when we are hyperventilating, it's causing what some kind of respiratory alkalosis, and it eventually leads to some hypocalcemia, leads irritability, anxiety, and jitteriness. What about coherent breathing is that we have to reduce our breaths in minutes So in order to relax the mind and regulate the nervous system. So breathing in through the nose for 6 seconds and breathing out through the nose for 6 seconds. Like we are reducing and we are using the nose for breathing purposes only. So this is a basic form of coherent breathing that can be practiced anytime and anywhere. Breathing in through the nose for the 6 second and chanting mantra or a word while breathing out through the mouth for 6 seconds. This is a form of coherent breathing that can help focus the mind and enhance the relaxation response. So here is on this slide, there is some scientific evidence related to CAM derived from clinical studies. So CAM use is common among patients with cardiovascular diseases with a prevalence ranging from 4 to 61%. Most frequently used CAM therapies are biological use, such as herb, vitamins, and supplements. Some of the reason of for CAM use are to improve quality of life, to prevent or treat symptoms, and to complement conventional treatments. So it may be influenced by factors such as place of residency and pattern of disease. So this table is showing some studies that were done in the past, because literature reviews doesn't show any recent studies regarding this. So I collected some studies that I was able to find regarding CAM. So in USA from 1990 to 2007, research was done, and 1 year prevalence of CAM use was from 34% to 42% in 1990s. It was 36% in 2002. It was 38% in 2007. While 1 year prevalence of visit to camp practitioner was 13% in 2002 and 16% in 2007, while quality criteria varies. While in UK, research was done from 1998 to 2005, and 1 year prevalence of CAM use was in between 20 to 28%, while 1 year prevalence to CAM practitioner in the UK was 10 to 14%, while quality criteria varies. In Canada, research was done from 1995 to 2005, and it shows 1 year prevalence to CAM practitioner, it was 12 to 17%. In Australia, research was done from 1993 to 2004, showing prevalence 1 year prevalence of CAM use was 49% to 52%. So this is the highest. It was seen during 19 to 93 up to 2004 in the Australia, while 1 year prevalence of visit to camp practitioner was 20 to 27%. This is highest as well as compared to other. So in other countries, in different era, data was collected and it shows result varies from 9.8 to 76% for showing 1 year prevalence of CAM use, while for 1 year prevalence of CAM practitioner, it was ranging from 1.8% to 48.7%. So what are safety and risk? So there is no regulation and standardization. Like there is no proper authority to control or to standardize or to justify and to make a check and balance on this CAM use. Sometimes they are potentially interacting with the other allopathic medication, so causing severe side effects. Sometimes they cause allergic reaction as well. So there is a risk of contamination. Like there is no proper authority to control and to control or to take part to check the quality of the substances. So that's why there is a risk of contamination. Adverse effect of herbal supplements. Like I was seeing a latest study in which it was mentioned excessive amount of beta carotene, that is what vitamin A, it can cause lung cancer in high risk patient. So like it's a herbal supplements and we are taking daily in our as a multivitamin in our diet, but it is causing a serious adverse effect of lung CA in patients who are at risk for cancer. And missed sometime, like there are no proper practitioner, they are not certified. So sometimes they misdiagnose the disease and cause delayed treatment, and it is causing psychological impact. Like patient is taking this scam like herbal medication, and he's saying like he's getting well, but there is no justification or there is no scientific evidence, and sometimes there are regulatory issues as well. So, challenges of CAM: lack of scientific evidence for the safety and effectiveness of some CAM therapies, potential interactions or side effect with the conventional treatment or medications, difficulty in finding reliable and trustworthy sources of information or practitioner of CAM. This is the main problem. First one is lack of scientific evidence. Second one is this: okay, difficulty in finding reliable and trustworthy sources of information or practitioner of CAM, lack of regulation or standardization of some CAM products or practices, cost and availabilities of some CAM therapies. So, what is our conclusion? So, CAM is a term that refers to medical products and practices that are not part of standard medical care, also known as conventional or Western medicine. CAM may be used by people with cardiovascular health problem to help cope with the side effects of treatment, to comfort themselves and ease stress, or to feel that they're doing something to help with their own care. So it may include natural products. We discussed herbs, vitamin and supplements, some physical methods such as massage, acupuncture, chiropractic, mind-body interventions such as meditation, yoga, and hypnosis. Thank you so much. Any question? Thank you.
Our study that was conducted in University Hospital in Osijek, which lasted from 2013 to 2020. So we shall present those results very soon. I cannot move my slides. Just let me see now. Can you see the next slide now? Which
No.
says you don't?
No.
Just
Okay.
Dr. Dragan, can you click on the slide number, which is on your left?
Okay, just give me a minute. Can you see now?
yes. We
No,
can.
okay. So, okay, we can carry on. So, heart failure is a great problem for society. We all know what heart failure is. According to European Society of Cardiology guidelines, we have now distinguished heart failure with preserved and reduced ejection fractions according to those numbers. It is a great problem because the incidence of heart failure is rising. It is affecting elderly people, and it has peaked around 85 and 94%, 85, 94 aged people, because our population is getting older every day, and of course it is reasonable to expect a rising of heart failure in those patients. Those people with heart failure have doubled in last 20 years, and we have seen secular trends that are showing the rise of heart failure patients. And if we can see the way we were treating those patients during the 50s and 70s years of the 20th century, we can see that there was a dramatic increase in survival rate, but after the 90s, there was not such a dramatic increase. Although we have very potent medicines now, including SGLT2 inhibitors and ARNI, we still need to do something. Economy of those patients is also very important because it affects lots of people. It affects elderly people. It presents to 10% of all hospitalized patients. And for instance, in the United States, it consumes 2% of total healthcare budget, which is a lot. Especially people with cardiac cachexia should be seen very early, because those people with cardiac cachexia have almost triple time mortality when you compare those patients to the normal, let's say, heart failure patients, because they have sarcopenia, and it is very, very bad for survival. So a holistic approach is very important to assess those patients. In our study, we used some of the instruments which are basically very cheap and easily accessible. We're going to talk about nutritional assessment today. Yesterday, we were talking about short physical performance battery, and we are now going to talk about nutritional risk assessment. So this is the example of mini nutritional assessment questionnaire. It is basically a questionnaire with scores. You ask patients something like about food intake, like about weight loss during the period of 3 months, mobility, psychological stress, neuropsychological problems, and you can really assess the patient and give them a score. It has been clinically recognized for a long period of time, during the 90s, and it needs to find older elderly people to see which one of them are increased risk of malnutrition. And so I was wondering, how can we see those people with those risks with heart failure to predict their mortality? We also were measuring in those patients serum levels of galectin-3, which is basically a molecule that represents the fibrosis in the body. So if you have kidney failure, if you have heart failure, you have more fibrosis, you have more fibroblasts in your organism, and they produce more galectin-3. So it is reasonable to expect in those patients to have higher levels of galectin-3. So we were wondering to see which one is a better predictor of 5-year mortality. So we used 260 subjects in our study. They were collected from 2013 to 2015, and they were monitored until 2020. So patients with COVID were not included mostly, and we didn't get messed up results because of COVID. So these are mostly really heart failure patients. There were more patients included in the beginning of the study, but some of them were excluded because of non-cardiac mortality, because people die because of traffic accidents, hip fractures, and so we didn't want to take these results into account. So every one of those patients were hospitalized in our university hospital center in Osijek in Croatia, and they were examined by experienced cardiologists, and they were with some X-ray and biochemical parameters, which were used to confirm clinically cardiac failure. So no other comorbidities were included into this research. So we didn't want to include, for instance, patients with SIRS or some other sepsis or some other comorbidities that can have a really big issue on 5-year mortality, so that would mess up our numbers. Statistical analysis was used. Mostly it was a multivariate Cox analysis to compare the mortality of those instruments we used. That was minimum nutritional assessment, short physical performance battery, and nutritional risk index. And we wanted to compare in our objectives of the study those instruments with galectin-3 and with anti-proBNP. So the survival rate was as expected. We were monitoring our patients for 5 years, and it was the survival rate was 52.7%, which is consistent with literature. We even took to see the correlation of galectin-3 level with some other parameters in biochemical and nutritional factors. For instance, we are talking about minimum nutritional assessment, and we could expect that those people with lower numbers of minimum nutritional assessment score and would have higher levels of galectin-3, but that was not the case. There was no statistically significant result in correlation between galectin-3 and minimum nutritional assessment. So when we got our first results for minimum nutritional assessment, the red on the left represents those who survived, and the yellow on the right represents those who died. It was like really significant number with P below 0.001 for MNA to predict 5-year mortality, and that was so great. But when we concluded, when we used additional statistical analysis for adjusting for age with multivariate regression analysis, we showed that there was no statistically significant difference. So we cannot really use MNA to predict 5-year mortality in patients with heart failure. Yesterday, I was talking about some other instruments like short physical performance battery that showed even after that adjustment for age with multivariate regression analysis, that short physical performance battery can be used for predicting mortality in heart failure patients. What is also interesting, galectin-3 didn't also show significance for predicting 5 years mortality. P-value was 0.472. So we cannot use, that's a really conclusion, not MNA, not galectin-3, but we can use some other instruments for predicting mortality, like short physical performance battery. So not performing MNA, but performing short physical performance battery can assess those patients who are in nutritional and functional deficit that can go to cachexia and who can have almost tripled heart failure 5-year mortality. So the basic thing is to find those patients on time, to see those patients, to give them proper nutrition, proper physical exercise, not to get developed cachexia, and to reduce heart failure mortality. So the limitation of the study was because, for instance, SGLT2 inhibitors were not present in Croatia at the time when we were collecting patients. Most of them were not on SGLT2 inhibitors. That's one of the limitations. We cannot really say the adherence to the therapy because we were not with those patients. They were contacted by phone every now and then until the 5-year monitoring phase. And we can still get those patients who survived, like 10-year mortality in the future, and it will generate some of the future works for us. So I thank you for your attention, and if you have any questions, share with me. Thank you.
Thank you very much.
And a few words about myself. I'm a professor of anesthesia in the Hebrew University of Jerusalem. And I was for several years the president of the Israeli Society of Anesthesiology. And I was a member of several task forces about sustainability of the European Society of Anesthesia and the World Federation Society of Anesthesiologists. Next. The term sustainability is global, but we would say that in different parts of the world, the meaning of it is different. International guidelines were developed for the developed and high-income countries, but unfortunately, the impact of climate change disproportionately is affecting low-income countries. And here you see an example in South Africa when the president said after huge disaster, flooding, it's a climate change. What can we do? And there were many, many other events like that in the last year. Next. So what is, can we see the top, the title of the slide, please? Somehow it's cut. The top line is cut from my presentation. Anyway, let's continue. Next slide.
The
Oh,
head.
now it's good. Now it's good. Next slide, please. Okay. So you ask yourself, what is how the climate is affecting our body, and why is this magic number of 1.5% and 1.5% Celsius is such a big deal? So it is a big deal because it affects malnutrition due to drought. There is a tendency that all the nutrition value of the planet are changing from protein to carbohydrate. And there is a name for that, the hidden hunger. And it's CO2 related deterioration because the CO2 is higher in the atmosphere, is deteriorate the nutrition. There is dehydration and starvation in children. We can observe natural disasters, as I showed before, and the heat affecting the body, the heart, the kidneys, cerebrovascular, and mortality is higher in elderly over 70 years of age. Next. So the objective of my lecture is divided into two. One is the low and middle income countries like the Sub-Saharan, Southeast Asia, and even some part of Europe. And we want to understand the differences in the concept, sustainability, which in different populations around the world. In Africa, and especially in Sub-Saharan, sustainability is more, you have to use the word continuity for resources and treatment. Next. In the high-income countries, the efforts are to attenuate the rise in global warming. And we face a big increase in global warming in the 21st century. And if you look The volatile anesthetics are part of the greenhouse gases which affect the global warming. We have a huge amount of solid OR pollution. And if you look in the oceans, in the Atlantic Oceans, just west of the Canaries, or in the west or in the Pacific Ocean, you may find islands of plastic waste. Next slide. So in the ocean, it's snowing microplastics. And it's basically create a 7 continent of dirt in the Pacific. These are fibers and fragments of polyamide, polyethylene, and they are altering the planet ancient cooling process. Right? And the sustainability in low-income countries, the problem is that the pagan medicine, the traditional medicine, is still dominant. There is a huge lack of skilled medical personnel. There is a huge lack of medical facilities. And for them to speak about sustainability, to protect the globe is just a joke. For them, basically, we speak about survival and continuity. Next slide. So, sustainable medical condition in these areas is continual supply of medical materials, well-functioning sterilization facilities, good maintenance of equipment, because they get donation of a lot of equipment, a lot of medical instruments secondhand arrive, but a small part is enough that small part is broken and the instrument is wasteless. And sustainable infrastructure of water, power, and waste. The main bodies which are working in those areas of the world are the Doctors Without Borders, or in French, Médecins Sans Frontières, the World Federation Societies of Anesthesiologists, the Smart Hospital Foundation, which is Canadian-based and European, and the Chinese are doing very good job with their Chinese overseas health assistance. And they send many Chinese medical teams. Next, okay. The problem is that maybe there are hospitals in the capitals of the low middle income countries, but the access for medicine in the rural communities is very difficult and is not affordable. Just think that that the poor village person has to go by bus for 12 hours to the big city. He cannot afford it. So they need the medicine and the medical assistance in their location. And therefore, it's important to secure governmental funds for training and accreditation and to support maintenance and management in the rural area. Next. And the national societies all over the world has a very important role to achieve international cooperation for education, to divert governmental budget to rural communities hospital, to achieve high quality medicine in the periphery. The single-use equipment is not always so. We are in a move to a single-use equipment, but where the workforce is cheap, Single-use instruments are not the solution, and reuse of medical equipment is much more realistic approach. Next. In the high-income countries, the ESA task force presented 5 R's: refuse, reduce, reuse, recycle, and research. Basically, how to review new disposable devices and using more reusable devices, how to recycle metal and plastic and paper and carton. And next slide. And in hospital, the motivation for conserving energy, hospital has to decide where to invest their limited budget, whether to invest it in new MRIs, new OR suites, or to use it for sustainability. In that point, the younger generation has its important impact. They hold a powerful influence on the management. The pressure starts from the bottom, and the motivation for the hospital to conserve energy is first ecological reasons, the climate protection, the environmental awareness, minimization of waste, but there are also economic reasons. They are saving costs, and they are showing they are ethically motivated. Next. The contribution of the young generation, students in health science have high awareness of climate crisis, especially within their institution. The urgency to lead changes that protect the environment has a priority, and they really want to be involved. They are the ones who will lead the trends throughout their career. They will lead sustainable programs in the health system that will be adopted by international health bodies. Slide. How can we save energy in hospital? First, we have to replace all the old type of lighting into LED. To turn off air condition, we are moving all our anesthesia cards to one operating room, which stays air conditioned all night. The rest of the ORs are turned off. The air condition is turned off. It is important to connect hospital to direct gas supply, and next, and to combine the heat and power technology. So what I want to say is that environment and economy can go together, and they can be reconciled. Next slide. So the next, so leave it like that. No, please, so that's it. One back. The combined heat and power technology is by bringing the gas supply directly to the hospital and to build a power plant in the hospital. Then the waste energy, instead of 70%, you use this heat energy to heat the hospital, to make hot waters, and therefore the waste is only 10%. Next slide. Now, what about the anesthesia gases, the inhaled anesthetics? And you are cardiologist, but this is what we call the anesthesia machine. But today we give it, it's more than an anesthesia information center. Why? Because we have all these monitors of the anesthesia machine, monitors of the patient, and the record-keeping chart. And we bring into the anesthesia machine the oxygen, the air, and the anesthetic gases. Next slide. But after I just keep few slides that what is the pathway of the gases, but in the end, they end up in the walls of the operating theater, and from the walls of the operating theater, they are going to the sky, poof, just like that. All the anesthetic gases are not filtered, are not processed, are not neutralized. Only 5% of the inhaled anesthetic are used. 95% are released to the atmosphere. Next. And they live forever. The nitros live 114 years. Desflurane, 14 years. There are different statistics. Some people say 28 years. So fluorine is less, live less in the atmosphere. Next. It came to the point the desflurane was declared in Europe and in the US that they will stop, although it's very excellent anesthetic gas, desflurane will be eliminated from our arsenal of gases from 2025. And for example, just to understand the magnitude of the pollution, the UK National Health Services reported that from all their pollution produced by the hospital, the anesthetic gases represent 5%. So if you want to offset vented anesthetic gases from one medium-sized hospital, you have to plan to put 1 square miles of trees every year to offset the anesthetic gases. Next. And when we speak about greenhouse effect, greenhouse effect is a good effect. It prevents that our globe will not heat too much. We have the layer of clouds, the layer of gases. It's a natural process which maintains the temperature. And only because the exceed accumulation of gases like CO2, inhaled anesthetic, methane, we consume the ozone layer, we cause holes in the layer, the natural layer, and then more heat can go into the ground. And that's why we see glacier melting. Next slide. Okay. So our mission, it is imperative for us anesthesiologists to efficiently eliminate the inhaled anesthetics from the operating theaters, from the hospitals, and from the atmosphere. This is a parking lot, which was designed very nicely. Next slide. So there are many efforts made in the past and in the present how to absorb the volatile anesthetics. The main use is product is activated charcoal, which has a very huge surface area, and they can absorb the volatile anesthetic. However, when it is saturated and you throw it away, slowly it's released back the volatile anesthetic to the atmosphere. So from the point of balance of the volatile anesthetic, you did nothing. Next. So my project is, and this is still not patented, so I cannot present it, but my project is how to basically to extinguish, to eliminate, to break the volatile anesthetic from, so they will not reach the atmosphere. So my last slide is do no harm. Our Hippocratic oath is do no harm. This oath should be extended to the environment. We cannot allow healthy people on a sick planet. Thank you. Any questions?
Thank you, Dr.
For years about the intrication of the melatonergic pathway and the endocannabinoid system through the melatonin cannabinoid type 1 receptors, heteromers. Yes, donc here you have a slide summarizing the effect of the two systems. For melatonin here, melatonin is a neurohormone that is synthesized in a circadian way by the pineal gland here, and is going to reset the peripheral clocks that are found inside the intra-body organs. It is involved in the sleep cycles, in neuroprotection, in glucose homeostasis, and in many other also functions. The melatonin is going to act through two membrane receptors belonging to the G-coupled receptor family. Just to remind you, the GPCR family is the largest protein family, and in human, you can find more than 800 proteins in this family. The two membrane receptors are bound with a high affinity by melatonin. This is the MT1 and the MT2. Both are coupled to a protein that is called GI, and the activation of GI is going to decrease the cyclic AMP level intracellularly. For cannabinoids, you have three types of cannabinoids. You have endocannabinoids that are synthesized by the body, and the two mains are anandamide and 2-arachidonyl glycerol. You have phytocannabinoids, like people are consuming when they are smoking cannabis, and the most abundant cannabinoid found in cannabis is the delta-9 tetrahydrocannabinol, or delta-9 THC, and you have also synthetic cannabinoids that are used for study. Role of cannabinoids also are very important in synaptic plasticity, in the reward systems, of course, in sleep induction, in neuroprotection. Cannabinoids acts also through two membrane receptors belonging to the GPCR family. The names are CB1 and CB2. Like MT1 and MT2, CB1 and MT2 are coupled to the GI family, and when the receptors are activated by the ligands, they will induce a decrease of the intracellular level of cyclic AMP, and this decrease will foster genomic action and the phosphorylation statute. Here, as an organ model, I will show you the results obtained with cerebellum. Why cerebellum? Because for the next study, for the next slide, I will show you that we need organs that co-express MT1 and CB1 to demonstrate some results. Here at the left part, you have an in situ in situ hybridization, where you can see that the mRNA encoding CB1 is found at a high concentration in cerebellum of a mice brain. At the right, you have a section of a human cerebellum that is labeled with radio label melatonin. And here you can find, donc this is an autoradiogram, and you can see here the different level of radio labeling by iodomelatonin. Donc in cerebellum, both CB1 and MT1 or MT2 are co-expressed. During the 20th century, the classical GPCR biology intended to see that the action of GPCR are at the plasma membrane. When GPCR were distributed at the plasma membrane, and when the ligand binds to the GPCR, it will activate signaling pathway and an action occur. But at the end of the 20th century and at the beginning of the 21st century, it has been shown that, in fact, GPCR are not acting only at the plasma membrane. It could act also intracellularly in the endoplasmic reticulum, in the Golgi, in the mitochondria, and also in the nuclear envelope. And in fact, donc, GPCR are found inside the cells, and they were found also to be functional. This is important. They are not only distributed, but they are functional. Here, this is a study showing the mitochondrial distribution and functional effect of the CB1 receptor and MT1 receptor. Working with purified mitochondria from neurons, the CB1 were found to be associated with the here this is an electronic microscopy image. CB1 were found to be associated with the outer mitochondrial membrane of mitochondria. The same was found for the MT1 receptor. This is purified mitochondria obtained from neuroblastoma neuro 2A cells. When people have measured the mitochondrial respiration, I must add that the mitochondrial respiration is a mitochondrial process that is going to synthesize the ATP molecules. Here, donc, when the mitochondria, purified mitochondria were incubated with increasing concentration of cannabinoid, there is a decrease of the mitochondrial respiration. This decrease is CB1 dependent because when mitochondria were purified from CB1 knockout mice, meaning that mouse that do not express anymore CB1, no inhibitory effect was found. Here, a parallel study was done in the MT1 receptor, but this time with transfected cells. Here, you have the level of respiration in presence of melatonin of cells that do not express MT1. Here, you have an inhibitory effect of cells expressing MT1, but about roughly is 20% inhibition. And this effect is MT1 dependent because when cells are expressing MT2, no inhibition was observed. There is also at the end of the 20th century, a major result was obtained. It has been shown that receptors on GPCR can interact with each other in a specific way, and that the heteromere that is formed could have some specific signalization properties or pharmacological properties. Here you have a list for the melatonin receptor and for the cannabinoid receptors. I will not go in depth into this, just taking one example. Here you have the example of the heteromere comprised of the MT2 receptor and the 5-serotonin 2C receptor. And this receptor has been shown to be a target for antidepressant molecules. And here you have the heteromere for the CB1 and dopamine D2 receptor that have been shown to convey some specific functional function in the central nervous system. At that point, knowing that CB1 and MT1 were co-localized in the outer mitochondrial membrane, that they have some function, that they share some function, especially for the neuroprotection, we wonder if the two receptors could interact, and if yes, if the heteromeres could be found at the plasma membrane and at the mitochondrial level. For this, we perform different kinds of experiments to show the direct interaction of CB1 and MT1. Here are immunofluorescence performed with two kinds of cell lines, the HEC293 cells, it is a human cell line, and the mouse neuroblastoma neuro2A cells. In red, you have an immunostaining of the MT1, and in green, an immunostaining of the CB1. And this is a confocal image taken with a microscope. And when you merge the two channels, the red and the green, you can see that you have yellowish colors that appear. The yellowish color means that the two colors co-distribute intracellularly. Donc there is a high level of co-distribution of the two receptors inside the two types of cells. Now, co-distribution does not mean that there is co-interaction. Here, to demonstrate that there is co-interaction, we used HEC293 cell lines, and we co-express in the two cell lines the MT1 and the CB1 receptors. We pull down the MT1 receptor using an antibody against a tag that was fused to the N-terminus of the MT1. The name of the tag was the flag tag. Donc you pull down the MT1 using an anti-flag antibody, and after you run the protein extract on a gel, and you do what it's called an SDH gel that enable the protein to be discriminated according to their molecular weight, and you try to identify the CB1 using an anti-CB1 or an here it's an anti-HA tag that was fused to the N-terminus of the CB1. So this is the results of the immunodetection after Western blotting. Here, when cells were co-expressing MT1 and CB1, we can see that after immunoprecipitation of MT1, we can obtain a signal with an antibody that identifies CB1. We obtain the 70 kilodalton band of CB1, that is the regular molecular weight of CB1, and we obtain also a 110 kilodalton band. We show that this 110 kilodalton band was also hybridizing with an anti-MT1 antibody. Donc it means that this 110 kilodalton was in fact an heteromere between MT1 and CB1. After, the previous slide was in vitro study, and we tried to identify the MT1 CB1 heteromers in vivo. For this, we use mouse cerebellum because we knew from the literature that MT1 and CB1 were co-expressed within the cerebellum. And we use 3 types of mouse. We use what we call wild type mouse, meaning that the mouse are expressing CB1 and MT1. We use MT1 knockout mouse that do not express MT1, and we use CB1 knockout mouse that do not express CB1. Why we use this mouse is because it's to be sure that the signals that we would obtain were specific, because the question of specificity is of high importance with antibody. This is an immunoprecipitation of the MT1 with an anti-MT1 antibody, and we try to detect the CB1 with an anti-CB1 antibody. This is the result of a Western blot after immunodetection with an anti-MT1. We can observe with a wild type mouse extract that we observe the 50 kilodalton and 60 kilodalton bands that was usually observed for the CB1. When we use MT1 knockout mice and CB1 knockout mice, we lose most of the signals corresponding to the 50 kilodalton and 60 kilodalton bands. Meaning that this signal is specific. And in fact, what we observe here is the CB1 co-immunoprecipitated with MT1, thus showing that, in fact, the CB1 MT1 heteromer exists in vivo in the mouse cerebellum. We show also with another technique that is called proximity ligation assay, or PLA. This technique enables people to identify proteins that are close at a distance of 40 nanometers or below. For this, we use primary antibodies to identify each protein, CB1 and MT1, and after we use secondary antibody that were linked to nucleic acid that were complementary. If the two secondary are close enough, the two nucleic acids that are complementary will form a duplex DNA, and we can get after a PCR reaction that will give at the site of the reaction some immunofluorescence dot. Here we have the experiments were performed on HEK293 cells and NEURO2A cells. Here cells, the experiment was done on cells that were not expressing CB1 and XP1, and we did not obtain signals. And here, when cells are co-expressing MT1 and CB1, we obtain these dotted immunofluorescence signals, meaning that we can find intracellularly complex of MT1 and CB1 that are at a distance below 40 nanometers. We also perform the same kind of experiment on HEK cells, but this time we address the question of the existence of this MT1 CB1 heteromer at the cell surface and not intracellularly. For that, we use non-permeabilized cells. The primary antibody could not have access to the target that were located inside. And we can find, in fact, also the PLA immunofluorescence dot at the cell surface. Meaning that, in fact, we concluded that in vitro, in our in vitro system, we can find MT1 CB1 heteromers intracellularly and also at the cell surface. Here, this is an analysis with with electronic microscopy done on egg cells that were co-expressing MT1 and CB1. And you can see here, donc this is the intracellular part of the cells full of ribosome. This is the extracellular part of the cells. And here is the plasma membrane. Here this time, the secondary antibodies that were used to detect the receptors were cross-linked to gold particles of different size, of 6 nanometers for the one that were to identify MT1, and with 15 nanometers for the one to detect CB1. You have different case here. You have gold particle of 6 nanometers gold particles here, donc corresponding to MT1 receptors distributed at cell surface. And you have examples of association of CB1, the 15 nanometers particles, and MT1, the 6 nanometers. Here, the distance between the 6 nanometers and the 15 nanometers are below 10 nanometers. Here in this example here, because we have one gold particle of 115 nanometers gold particle and 116 nanometer, the distance here between the center of the two particles is 6 nanometers. Donc, in fact, we can also show by electronic microscopy study that we can observe MT1 CB1 heteromer at the cell surface. And the question of the stoichiometry of how many CB1 receptors or how many MT1 receptors are involved in this MT1 CB1 heteromers are not solved for the moment, because it seems that higher order can be observed, like, for example, 2 MT1 with 2 CB1. But we have not addressed specifically this question because it requires experiments that we do not handle in the lab. Here I'm going to show you experiments performed with interfering peptide. Now, what is interfering peptide? In fact, interfering peptide is short synthetic oligopeptide of 10 residues long. And at the N-terminus of this interfering peptides is fused the sequence of what is called a TAT sequence of the HAV virus. And this TAT sequence is giving to the interfering peptide the capacity to be incorporated into the plasma membrane. Here, the sequence of the interfering peptide, here the example is the CB1 5-HT2A heteromers that are already described in the literature. People have shown that when they use the sequence of the transmembrane 5 or the transmembrane 6 that are around here of the CB1 receptor, they can compete with the dimerization interface, and they can dissociate the CB1 5-HT2A heteromers. Donc, this is a very powerful and specific tools to study only the properties of the heteromer of interest. We used the TM5, TM6, and TM7 that were defined in this previous work to study the CB1 MT1 heteromers. Or for this, I must introduce the technique that is based on energy transfer. Protein A and protein B for us are CB1 and MT1 receptors. Here you have large bit and small bit. In fact, this is an enzyme that is called nanoluciferase that can be divided in two parts. One part is large bit and the other part is small bit. When the enzyme is divided in two, the enzyme have no enzymatic activity. But when the two parts are close together, there is complementation and the activity of the enzyme is going back. Donc, this is a way also to test the proximity of the two receptors. And here, donc the enzyme is nanoluciferase. Nanoluciferase is going to produce light, and the light is going to be collected by what we call an acceptor, what is YFP, and the activated acceptor is going to release the light at another wavelength. Donc here it's here the acceptor is collecting at 480 nanometers and is going to be deactivated at 530 nanometers. And you have machine now that enables you to collect light at specific wavelengths. Donc this is a complementation assay. Donc in HEC cells, we co-express MT1 and CB1 fused to large bit and small bit. And here it's the luminescence of the reconstituted nanoluciferase. Here in the, donc this is a basal. When we co-incubated cells with the interfering peptides corresponding to TM5, we got a decrease of the luminescence. And this decrease was not observed with the TM6 and TM7 interfering peptides, meaning that the demyelination interface between MT1 and CB1 involved TM5 and not TM6 and TM7. Thereafter, we used this complementation assay to monitor the traffic of the receptor inside the cells. The traffic of protein in cell biology is the change in compartments following, for example, ligand activation. And here we used a biomarker of the plasma membrane compartmentation. Donc this protein, the GAP43, we know from the literature that is only localized to the plasma membrane and not in the nucleus, not in the mitochondria, only at the plasma membrane. And here we measure not we measure the exchange of energy between the nanoluciferase and the YFP at 530 nanometers. Donc here is the exchange of energy in absence of ligand. In presence of S2928, this is an inhibitor of the melatonin receptors, 1 and 2. Here, this is the exchange of energy in presence of 10-8 molar melatonin. And we show that we have a decrease of the exchange of energy, meaning that, in fact, the complex here is internalized and can no longer activate the GAP43 YFP. Here, it's 10-8 melatonin in presence of an inhibitor, and we abrogate the inhibition, meaning that this inhibition here is MT1 dependent. And this is the same result with a lower concentration of 10-9. Donc, in fact, the MT1 CB1 heteromere can be internalized by the melatonin through the activation of the melatonin 1 receptor. And what happens after to this complex? And for this, we used biomarker of the early endosome or the late endosome. The biomarker for the early endosome is RAP5 YFP, and for the late endosome is RAP7 YFP. And here we measure the exchange of energy at 530 nanometers. We can see that the inhibitor does not change the initial signal, but when we incubate with 10 minus 9 molar melatonin, we got an increase of the exchange of energy, meaning that the MT1-CB1 is going from the plasma membrane to the early endosome. And we observe the same thing with the RAP7, an increase of exchange of energy in presence of melatonin. And again, the co-incubation of melatonin with the melatonin inhibitor inhibits this increase of energy, meaning that this change here, the traffic here, is melatonin 1 receptor dependent. As we knew before that the melatonin 1 receptor and the CB1 receptor were located at the outer mitochondrial membrane, we address the question of the localization of the MT1-CB1 heteromere at the outer mitochondrial membrane. For this, we use the proximity ligation assay that I have described in the previous slide. In addition, we stain the mitochondrial network with a protein that is called TOM20 that is known to be located at the outer mitochondrial membrane. Donc here, this is an immunostaining in green of the mitochondrial staining, donc, shown by TOM20. And here, this is the PLA labeling of only the MT1-CB1 heteromere. And when we superpose the two channels, the red and the green, again, we see that there is a huge proportion of the signal that is going to get yellowish, meaning that it seems that the MT1-CB1 also is co-localized intracellularly with the mitochondrial network. We cannot say at this point that the MT1-CB1 is found at the outer mitochondrial membrane because the precision of the immunofluorescence labeling is within 200 nanometer range. And to get to say that it's inside the outer mitochondrial membrane, we must go at the 10 nanometers range. Here, this is an interesting experiment done on the mitochondrial respiration performed on purified mitochondria, either from HEC293 cells or from mouse cerebellum. Here we have the level of mitochondrial respiration. Donc you can measure the mitochondrial respiration with an electrode that is going to measure the concentration of O2 into the medium. Here, this is the level of respiration in the presence of a cannabinoid agonist. This is a synthetic cannabinoid agonist. It is called Win2 at the concentration of 100 nanomolar. Let's say that this is a basal level for us of 0. When we add 1 micromolar of Win2, we got a 25% reduction of inhibition. That was the thing that was usually obtained. Here, at 100 nanomolar melatonin, we got nothing. And at 1 micromolar, we get a 25% inhibition. The 100 nanomolar concentration for both are called suboptimal concentration because you do not get any effect at this concentration. But when you combine the two molecules, melatonin and Win at the suboptimal concentration, this time you got a synergistic inhibitory effect of 25% reduction. This synergistic effect is dependent of MT1 because nothing is obtained with MT2. here, when we use donc the mouse mitochondria from the mouse cerebellum, this time the suboptimal concentration is 10 nanomolar and no 100 nanomolar. We got an effect at 100 nanomolar inhibition. Inhibition also at 100 molar and 100 melatonin, and we combine when we combine the two molecules at a sub concentration of 10 nanomolar, we obtain a synergistic mild that is statistically significant. Donc it seems that from these studies that the MT1 and CB1 the MT1 and CB1 receptors synergize to inhibit the mitochondrial respiration. If it is through the MT1 CB1 heteromer is not known for the moment because we have to do experiment with the interfering peptide. This is ongoing. Donc, the take-home message are donc the MT1 and CB1 receptor heteromerize, and these things were not known until now. They are detected in the mouse cerebellum, and we know that MT1 and CB1 co-express in other organs like pancreas or in adipocytes also. MT1 CB1 heteromers are found intracellularly and at the cell surface. They are, the heteromers are linked to the mitochondrial network, and activation of MT1 and CB1 receptor give a synergistic inhibition of mitochondrial respiration. I want to thank all the people that were involved in this work, and it requires a collaboration between our lab here in France with another lab in France and also with another lab in Spain. Thanks for listening me. Do you hear me?
Yes, yes. Thank you very much.
Time to recovery and its determinant factors among patients with COVID-19 in Asusa COVID-19 Treatment Center, Western Ethiopia. Let us see outlines of the presentation. First, we will see a background of the study, then objectives of the study, methods, result, conclusion, and finally we will see about strengths and limitations of the study. Background: the coronavirus pandemic is an outbreak which is emerged in December 2019 in Wuhan City, China. After 3 months, the disease was declared a global pandemic by the World Health Organization on 11 March 2020. This is the reference for WHO standard. Determining the time to recovery from COVID-19 is intended to assist healthcare professionals in providing better care and planning logistics. So researching factors that affect the time to recovery from COVID-19 is very important, since the disease severity, days, and the recovery from the virus vary or differ from one individual to another due to different factors. Previously done studies showed that factors of older age and presence of pre-existing comorbidity delayed or prolonged the recovery time from COVID-19. The previous done study found that the median time to recovery from COVID-19 was based on this research 30 days with the range of 9 to 70, 18 days with the range of 10 to 70 out of this. So this recovery time variation this recovery time variation from one study to another needs further investigation. Therefore, our study aim or the objective of my study is to identify the factors that affect the time to recovery for COVID-19 for patients treated at ASOSA COVID-19 Treatment Center, Western Ethiopia. Let us see methodologies, methods. In this study area and design, the study was conducted at ASOSA COVID-19 Treatment Center, ASOSA Western Ethiopia. It is a study area. And also, as I've seen the study design, a retrospective study design was carried out from February 2021 up to July 2021 at the ASOSA COVID-19 Treatment Center. The source of population and data collection procedure, as we have seen indicated from the source, COVID-19 patients who were under follow-up of COVID-19 treatment at ASOSA COVID-19 Treatment Center were the source of the population for this study. And as we have seen the data collection mechanism, since it is previously collected data, we have used secondary data collection methods. Therefore, inclusion and exclusion criteria. Inclusion criteria, the patients diagnosed with COVID-19 at the treatment center within the study period, the patients who have been admitted to the treatment center for at least 3 days follow-up, patients who have complete medical records and information available for analysis, and patients of all age groups were included in the study as exclusion criteria. And as an exclusion criteria, we have used for exclusion from the study subject, patients who have not completed their treatment or are still in the early stage of treatment, patients who have been transferred or discharged from the treatment center before recovery or without complete recovery time data, and patients with missing or incomplete medical records or information necessary for analysis were excluded for this study. And this criteria, and exclusion criteria will help ensure that we select a representative sample from the total population while excluding individuals who may introduce bias, and component patterns study finding. Overall, a total of 962 COVID-19 patients were identified during the study period, but after applying the inclusion criteria, we have only used 334 patients for analysis. We have used these subjects. Variables in the study. The outcome variables considered in this study was the time to recovery from COVID-19, that is, the time from the start of the treatment until they recovered or censored. If they recovered, we said 1 if we get an event of recovery, and 0 if it is censored. Covariates for the independent variables considered were age in years, sex, male and female, COVID-19 severity status, comorbidity, chronic respiratory disease, asthma, presence of symptoms, oxygen saturation, and respiratory symptoms were used as an independent variables or factors for our dependent variable time to recovery. Let us see the analysis. We have used survival data analysis. Survival data is used to analyze data in which the time until the event is of our interest. If our interest is the time from the start of the treatment until they get an event of recovery or an event of sensor, we use this one. We used the survival analysis. We used the survival analysis to identify factors that affect the time to recover from COVID-19. Discrete analysis were used graphically by using Complementary survival estimates, and also by using statistics using log-rank tests. Log-rank tests are used for testing whether the survival experience of different categorical covariates. The proportional hazard assumption was checked by using the Stonefield residual test. Fox proportional hazard regression model was used to identify the potential risk factors that affect the time to recovery from COVID-19. This is the statistical model for the Fox proportional hazard model. In this Fox proportional hazard model, we used adjusted hazard ratio, p-value, and 95% confidence interval were used to assess whether each independent variable have a significant factor for our dependent variables or not. We use these criteria. If a variable p-value is less than or equals to 0.05, we say that this variable have significant effect to the dependent variables, other than it is not insignificant. It is, it is not significant, or we say that it is insignificant. As well as the parameter estimation technique, we have used maximum likelihood estimation technique, and after after fitting the model to the data, the accuracy of the fit model to the survival data will be checked using Fox residual and martingale residuals were used to check whether the model fits the data well or not. And also, we have used stepwise variable selection methods to select the potential variables which can affect the time to recovery from the COVID-19. Let us see results. In the results, social, demographic, and clinical variables with their sensory metastasis. Here is the variables: sex, severity, or morbidity, presence of symptoms, and the like. And here is the categories with respect to variables. Here is observed events or the patients who have recovered from the disease. And here is sensory and total number of respondents are here. The summary statistics of predictor variables in the data were displayed in this table 1. Table 1 means that this of a total of 334 COVID-19 patients, 77.2% got the event of first recovery, and the rest 22.8% were censored, or they have not recovered at that period of time. The majority of the patients, that means 51.5%, were males. As we have seen from this, females, sorry. Okay. And also males, 34.7% of the patients have related comorbid illness. And also the mean standard deviation of age after treatment is, or the mean was 45.2, and the standard deviation was, standard errors was 12.50. And also the next table to that the mean and recovery time, the mean and median recovery time, as indicated from this table 2, the mean recovery time was 70.573, and the median recovery time was 60 days. 60 days here is measured in day. Okay. Let us see the Kaplan-Meier survival curves. As we have seen from this Kaplan-Meier survival curves, the Kaplan-Meier survival curve provides an initial insight into the shape of the survival functions. That means, here is the shape of the survival function curve. Figure 1a means that this figure indicates that as time increases, the graph decreases rapidly. As time increases, the graph decreases rapidly. That means as time increases, the patient's waiting time with COVID-19 decrease. That means as time increases, most of the patients, as we have seen from the derivative, most of the patients, 77 points, something were recovered as time increases. And also, as we have seen from figure 1b, one means that Kaplan-Meier curve for sex suggests that the length of recovery time for male patients was greater than for female patients. That means male patients take longer time to recover than female patients. That means the curve for male patients was higher than the curve for female patients. So that means female, indirectly, female patients recover in a short period of time as compared to male patients. And also, figure 1c means that Kaplan-Meier curve for presence of symptoms. And this also patients who have one or more symptoms takes longer time to recover as compared to patients who have not any symptoms in the when he or she gets in the quarantine. And also, figure 1d suggests a primary curve for comorbidity. And this also, patients who have one or more comorbidity recover in a longer period of time as compared to patients who have not any comorbidity. That means the patients who have either TM, either HIV, or any other takes longer time to recover as compared to patients who have patients who are healthy at healthy and here is Cox proportional hazardous model. Here is a model variable selection in Cox pH assumption. The study used a purposeful variable selection method to determine the variables to be included in the survival models are not. And this is the proportional hazard assumption asserts that the hazard ratios are constant over time. That means the risk of failure must be the same no matter how long subjects have been followed, no matter how followed. And Cook's proportional hazard assumption test. We have tested whether our data are used Cook's proportional hazard model or any other survival model. We can test by using Cook's proportional hazard assumption test. To test Cook's proportional hazard assumption, we have used a global test. Was used. Here is a global test. As far as from this table, the p-values of all independent variables age is 0.176, 0.09, and the like. All variables have p-values greater than 0.05. And also the global system have the p-values 0.326. Here is also greater than 0.05. This indicates that the proportional hazard assumption for the Cox model is not violated. Since the Cox pH assumption is not violated, the data were used by the data were analyzed by using Cox pH model. As we have seen from this table, here this table is the multivariable analysis of the Cox pH model, and this the rate of the sex have adjusted hazard ratios 4.9201 with p-values with 0.0001, which is less than 0.05. This indicates that the rate of achieving recovery for female patients, these female patients, was 4.9201 times higher than for male patients. That means the time needed to reach recovery for female patients was significantly shorter than male patients, and the rest variables can be interpreted in the same way. Here is also interpreted as the same way. The next one is model diagnosis. Once the model is fitted, the next step is to verify the entire necessary model assumptions are valid in the selected model. To check this model assumption, we make use of standard types of residual proteins to validate the assumption behind the Fox pH model. As you have seen from this figure too, the Fox scale residual proteins of the COVID-19 patients, as you have seen from this, the several functions of series curve, several functions of the unique exponential distribution indicators that the several function of the standard exponential distribution is within the 95 confidence interval. Percent confidence interval of the Kaplan-Meier estimates. That means the red lines are between this 95% confidence interval. Therefore, and also, as you have seen from this residual proteins for significant predictors, the DF beta residual proteins were randomly distributed. That means here is randomly distributed and it is not symmetric. And the loss smoothing plot, the loss smoothing curve does not exhibit more departure from the horizontal line. Here, or horizontal line of the origin. This indicates that the selected survival model, Fox pH model, fits the data well. You can say this. And discussion, in this study, we assessed the determinant factors that prolonged or shortened the recovery times of COVID-19 patients who were admitted at ALSha'ab COVID-19 Treatment Center. This study demonstrated that the median time to recovery from COVID-19 was, as we have seen from the table in this gravity, the median time to recovery was 60 days. This is more or less similar to another studies. Here are some studies done by Abraham and also Second and Teresa. Those are, it is more or less similar to the studies for the time to recovery for this study. This may be due to the treatment given to the patient as being somewhat the same, and also this may be due to similar characteristics of the study participants based on the study factors, factor variables. However, this study was contradicted to another study. This may be due to the immunity study, the immunity of the patient, the participants in the study will be better than this. For this study and for this study, the median time to recovery was shorter as compared to my result, my finding. And also, age was an important clinical variable of time to recovery, implying that as age of the patients increase, the rate of attaining recovery decreases. That means, as age increases, the patient's waiting time with the virus increase. This this result was also consistent with another study. In this study, in their finding, the time to recovery decreases with increased age. That means older patients recover in a longer time as compared to younger. That means directly younger patients recover in a short period of time as compared to older patients. In this study, we found a significant association between the sex of the study participants and the time to recovery. This result was consistent with this and this study. In their finding, female patients recover in a short period of time as compared to male patients. This result was also consistent with another study. However, this study was contradicted by another study. And in their finding, the recovery time of male and female patients was nearly similar. This nearly similar. And also, patients who have related comorbidity illness prolonged recovery time in the study. Next, strength and limitation of the study. Strength and limitation of the study. The strength of the study. Okay, this study was done by a well-defined statistical model, and this should give a more appropriate result. And also as a strength, since there were a scarce of studies done in Western Ethiopia, this finding was used as input for other studies who wanted to do research in this area and elsewhere. As a limitation, our findings were also subject to some limitations. There could be a chance that the duration of mild coronary symptoms may be overlooked by the individuals and the life. And also, the study could not identify other non-clinical predictors, since it is not reported in the treatment center. Concluding, in general, this study found the factors that prolonged or shortened the recovery time for COVID-19 patients. The study concludes that severe COVID-19 patients, male patients, patients having other related diseases, older patients, patients having symptoms as two prognostic factors and prolonged recovery time. Therefore, healthcare providers and treatment centers should give a strict follow-up and priority to older patients, severe COVID-19 patients, and patients having other comorbid illness by focusing on respiratory difficulties and underlying pre-existing medical conditions to manage the disease severity and recover quickly. Here is the references we have used for analysis. Thanks for your attention.
Thank you, Dr. Morrow, for your great.
Already, so let me start from the abstract. So heavy metals exposures has been linked to several detrimental health outcomes, including cancer, neurotoxicity, and cardiovascular diseases. So this review, we only summarizes scientific research on sex-specific vulnerability to heavy metal toxicities. So from the introduction, so heavy metals are sort of an environmental pollutants that can be dangerous to human health and is present in many environments. Some of the examples are lead, mercury, cadmium, arsenic, and all of them has been linked to have caused so many harmful diseases, which cardiovascular diseases is included, and some neurodevelopmental abnormalities. And that is according to Agency for Toxic Substances and Disease Registry in 2019. So heavy metal exposures can have an impact on sexes, although research indicates that the health effects may differ depending on sex. And that's according to Ali Ita in 2018. So for the purpose of time, let me go to the mechanism of heavy metal toxicity. So heavy metals are dangerous substances and can adversely affect people's health. So through environmental contamination, such as occupational exposure or consumption of tainted food or water, people may come in contact with these contaminants, and that's according to WHO in 2010. Cancer, neurological issues, and CVDs are just a few of the detrimental health effects that heavy metals have caused. According to studies, the sensitivity to the heavy metal toxicity varies between the sexes, with often women showing more risk than men. So women tend to show more risk. They are most exposed, or their risk factor is much higher compared to men. One aspect that led to disparity in toxicity between the sexes is variances in the absorption and the distribution of these hazardous metals. Females typically, they have a higher percentage of body fat than males, which can serve as a storage space for these heavy metals. So female may therefore circulate more heavy metals, which increases the likelihood of their poison. So in addition, women typically ingest more calcium, iron, and other micronutrients, which can compete with various heavy metals for absorption in their digestive mechanism. So let me go to the differences in their distribution and absorption and in excretion. Heavy metals exposure has been associated with harmful effects on male reproductive functions, including the reduced sperm quality and quantity, testicular damage, and hormonal imbalances. The toxic effects of heavy metals on the testes and sperm, as well as the disruption of hormone production and regulation, are believed to be the underlying causes of these effects. That's according to Joix and Anke in 2006. So women's menstrual cycle irregularities, decreased fertility, and poor pregnancy outcomes have all been linked to these exposure as well. Similar to this effect seen in males is that heavy metals can impair the ovarian function and influence hormone synthesis and control, as according to Salem and Rahman in 2004. So reproductive and developmental effects of heavy metals. So ROS, that's reactive oxygen species, which are produced as a result of oxidative stress caused by heavy metals, can be damaging to the organism. And according to Jill and Tetujan in 2010, ROS have the potential to harm biological elements like proteins, lipids, and DNA, which can result in cell death, inflammation, and other health issues. So numerous illnesses, including cancer, CVD, and neurological disorders, all of which are correlated with oxidative stress. They have been linked to these heavy metal exposure. So, and the estrogen and testosterone, which are sex hormones, they may play an important part in moderating the effects of heavy metals as well. So important hormones, including testosterone, progesterone, and estrogen, control many physiological functions like the metabolism, immunological response, and reproduction. So heavy metals such as cadmium, lead, and mercury, they can build up in many tissues and organs, and they can cause cellular injury and dysfunction. So according to literatures, there are a variety of ways that sex hormones and heavy metals might interact. For instance, estrogen can attach to metal ions and interact with them, creating complexes that can build up in tissues, and they can be harmful in the course of time. So the reproduction of antioxidant molecules can also be increased, and the expression of enzymes involved in heavy metals detoxification can be affected by testosterone, and potentially providing protection from the toxicity of these heavy metals. So let me quickly rush to the heavy metals and cardiovascular health, which is related to the title of this conference. So exposure to heavy metals have been linked to cause a range of cardiovascular health outcomes, including hypertension, atherosclerosis, and heart failure. And that's according to Gonzalez, Mose, Itan in 2021. Heavy metal exposure is a global public health issue that affects millions of people worldwide. CVDs are the leading cause of death globally, that is next to cancer, accounting for an estimated number of 17.9 million deaths in 2018 according to WHO in 2021. So there is mounting evidence to suggest that heavy metal exposure can lead to cardiovascular damage, which can ultimately lead to CVDs. And however, recent research suggests that there may be sex differences in the impact of heavy metal exposure to cardiovascular health. One of the most well-studied heavy metals in relation to CVDs is lead. Lead exposure has been linked to a range of cardiovascular outcomes, including hypertension, coronary heart disease, etc. Studies have found that men with higher levels of lead in their blood are more likely to develop hypertension than women with similar levels of lead exposure. That's according to Navasation in 2004. This suggests that men may be more vulnerable to the cardiovascular effects of lead than women. And cadmium is another heavy metal that have been linked to cardiovascular damage. And cadmium exposure have been associated with endothelial dysfunction, which is a risk factor for CVDs. That's according to Liu et al. In 2018. One study found that men who were exposed to higher levels of cadmium had an increased risk of developing CVDs, while women with similar levels of cadmium exposure did not have an increased risk. So this suggests that men may be more vulnerable to cardiovascular effects of cadmium than women. So mercury is another heavy metal that have been linked to CVDs. Mercury exposure have been associated with hypertension and other CVDs. So some in 2019 found that men with higher levels of mercury in their blood had a greater risk of developing hypertension than women with similar level of mercury exposure. So in this review, then we now suggest that this suggests that men may be more vulnerable to cardiovascular effects of mercury than women. So the mechanism underlying sex differences in the impact of heavy metal exposure on cardiovascular health are not yet fully understood. However, it is thought that sex hormones may play a vital role. Estrogen, for example, has been shown to have a protective effect of the cardiovascular system. So some studies also suggested that estrogen may protect against the cardiovascular effects of heavy metal exposure. Testosterone, on the other hand, has been shown to have a negative effect on the cardiovascular system. Some studies have suggested that testosterone may increase the vulnerability of men to CVD's effects of heavy metal exposure. So there is mounting evidence to suggest that there may be sex differences in the impact of heavy metal exposures on cardiovascular health. So men may be more vulnerable to CVD effects of lead, cadmium, mercury than women. So the mechanism underlying these sex differences are not yet fully understood. So we suggested that more research should be conducted on that. But sex hormones are thought to play a major role. So further research is needed to better understand the mechanism underlying these sex differences and to develop effective strategies for reducing cardiovascular impact of heavy metal exposures in both women and men. So thank you very much.
Thank you, Dr.
Okay, we're going to talk introduction, objectives of the study, methodology, result and discussion, conclusion, limitation of our study, and recommendations. finally, the references. So, sorry. Okay. Chronic obstructive pulmonary disease is known cause of morbidity worldwide. So assessing the treatment adherence is complex, but many methods have been proposed for COPD, like clinician estimate, patient self-reporting, pharmacy course, and electronic monitoring. It was necessary to identify factors related to adherence in order to develop more effective strategies in the future to improve medication adherence. And there is scales named 4-item Morisky and 8 items Morisky medication adherence scales. They are generic self-reported medication taking behavior scales, and they are considered to be most used self-reporting method to determine the adherence in chronic diseases. The aim of our study was generally to assess the medication adherence in Sudanese patients treated for COPD in ALSha'ab Teaching Hospital in 2019. To assess the COPD patients' inhaler techniques, to identify the underuse of the medication in form of suboptimal or interrupted doses, and to determine the financial impact of the medication to COPD patients. The method that we obtained was that the study was observational, hospital-based, cross-sectional study. It was conducted about 100 patients, among 100 patients of COPD patient attending outpatient clinic in ALSha'ab Teaching Hospital in Sudan. It is one of the largest referral centers for pulmonary disease. And it was, the duration was from February to May 2019. Okay, the population was COPD patients diagnosed with COPD. Inclusion criteria was that they should be diagnosed with COPD for 1 year or more from both sexes, female and male. COPD patient attending the outpatient clinic. The exclusion criteria was age less than 18 years and refusal to participate in the study. Okay, the data collection was through questionnaires. This was including adherence to COPD therapy using the Morisky medication scale for items, the age, gender, smoking status, treatment regimen for COPD, and COPD medication cost per month paid by the patients. And data was analyzed using SPSS version 21. And using chi-square to vibrate the analysis to identify independent factor for adherence. And p-value was considered significant at level of 0.05. So talking just few talk about more risky medication at scale, maybe most of us doesn't know about it. So it is, like I said before, it is self-reported, well-validated instrument. It has 4 items, including in its name, like taking the medication, carelessness, stopping the drug when the patient feels better, or stopping the drug because they believe it makes them feel worse. So all the question of the scale refer to only for medication given for COPD. And scoring of yes equal 1 and no equal 0 was employed. This is how to interpret the scale. High adherence, so 0. Medium adherence scale score 1 to 2. A low adherence 3 to 4. So resultant is and discussion of our study. It is a total of 100 COPD patients included. Almost half were 40 to 60% years old, and about 40% were illiterate. The majority were married, like 85%. Ratio between male to female was 2.7 to 1. Okay, and this already we talked about this table. And the smoking status, surprisingly, 54% were non-smoker, ex-smoker 26%, and currently smoker 20%. So we include in the questions the concurrent disease with COPD, like hypertension, diabetes, were like 29 and 27, and cardiovascular disease was only 4%. The duration of COPD disease itself was mainly 5 to 10% in 49% of patients. Talking about the occupation, 37 were employed, unemployed was 10%, retired was 28, and housewife not having any job, just at home, were 25%. Also, the administration route, like most of them were taking inhalers, 57%. Oral route was just 4%, and oral and both of them oral and inhalers in 39%. Okay. Medication dose per day, most of them were taking 2 doses per day. Okay, and proper knowledge of inhaler technique was found in 66%. Some of them were having some difficulties in inhaler technique in 28%. 72% were having no difficulties. And talking about number of medications also, most of them were taking more than one medication, and most of them were not having any side effects. Support of the patient were family, mainly family support, 73%. And medication cost was like most half of them were, or just more than one half, having that they told that the cost is affordable for them, and 48 were talking about not affordable. So this is the main point of our results, the adherence level. Talking about this, the adherence level was high only in 15% of patients, and 47% were having medium level, and low level in 38%. So the level of adherence is considerably low in COPD patient, included in our study, and 62%, including the medium and high, were found in our study. This was similar to a study done in Hungary, 2011. They mentioned that self-reported adherence in COPD to be 58%. And in our finding, this was lower than Maria and al., who did the study in 7 Latin American countries. They found that 80% adherent to medication. So there are some factors related to medication, significantly affecting adherence. These were age, education, and marital status. Okay, talking about age, more than the older the age, the more the adherence. So age more than 60 years, we're having 27% of them were found to be highly adherent to medication. While patient aging 40 to 60 years were found to be lower adherent to drug in 53%. This was consistent to et al., who were found that older patients were more adherent also, and Maria et al. In Latin American countries, several Latin American countries, they found also that more adherent to medication related to younger age. Sorry, older age. Marital status also was related in our study to medication adherence. The married patients were found to be more adherent. There are some factors not related to adherence in our study, were gender. So this was similar to previous studies also. The occupations of the patient, the smoking status in our study was not significantly affected. This was inconsistent with systemic review done in Australia, also in America and Egypt, who reported that adherence score is lower in smokers. And also presence of other comorbidities, duration of the COPD, and support type was not related also to medication adherence. So this was like in general, but we have factors related to medication itself, like the doses, the cost, and everything. And so this table talking about them, but we can summarize this to factors affecting medication adherence, medication dose per day. So 50% of patients in our study were taking one daily drug dose. They were highly adherent. This 50% of them were highly adherent to medication, while patients were taking more than 3 daily dose. 73.7 were found to be less adherent to medication. This actually was like a study done in Hungary, et al. 2011. Also, the patients that taking more than 2 daily drugs seem non-adherent compared to those with less than 2 drugs. And administration route also, the oral route was found to be more adherent, maybe because easier or something. And proper knowledge of inhaler technique. The patients who were aware of how to use inhalers were highly adherent, not like the patient who were unaware, with a ratio of 22.7 versus 0%. Difficulty inhaler techniques, patient who did not face any difficulties using the inhaler, they were highly adherent compared to patient facing difficulties. A number of other medications, the patient who were taking one drug showed a high level of adherence compared to those who were taking more than 2 other medication. So this also medication cost. The patient who were talking that the drug cost was affordable for them showed high level. This was like a study done in USA. They found also that it is related to the cost. Factors that not significantly affecting was a side effect of COPD medication. So conclusion that the study generally indicates that the level of adherence to COPD therapy is low. And to understand the factors associated with medication adherence is important to enhance the treatment outcome. And in our study, non-adherence was associated with middle age, unmarried patients, number of respiratory drugs, number of daily respiratory doses, low knowledge of using, increased difficulty with inhaler use, administration route, and non-affordability of the drugs. We have some limitation in our study that we need larger size to be more reliable. We have to have more reliable result. And it is clear that there is need for more researches in this field to determine the effect of intervention and strategy for improving medication adherence for COPD patients. Recommendation, consideration of medication adherence should be a routine clinical practice to optimize the management of COPD patients, which could lead to decrease level of burden of the disease in long term. And raising the awareness of medication adherence and medication using in patient is recommended to optimize the management of the disease. And less frequent doses regime should be implemented for COPD patient because it could be an effective method of enhancing adherence to COPD patients. And also good relationship between patients and healthcare provider is the aspect of education and communication are recommended. This is where my reference is. And thank you for listening. Any question? Hello?
Thank you, Dr. Ibrahim. That was a great.
Conducted with a 51-year-old male in an effort to gain insight into the perspectives of a master athlete. The purpose of the presentation is to shed light on the growing population of master athletes, the importance of collaboration for healthcare providers who serve this unique group, as well as to inspire many others to rise above the mundane and achieve greatness at any age. So let's first begin with defining master athletes. Previous literature has defined a master athlete as one who is typically older than 35, who either trains for or takes part in athletic competitions, often specifically designed for older adults. Presently, the U.S. population for the number of Americans considered older or identified at the chronological age of 65 and over continues to grow. It has been projected that by the year 2030, 1 in 5 Americans will be an older adult. At this time, all baby boomers will be turning 65 years old. The cohort of older adults who are commonly referred to as the baby boomer generation, they were born post-World War II between 1946 and 1965. The slide 6 of the presentation is a modified visual display of future projections for the older adult population in the United States, as reported by the U.S. Census Bureau's 2017 National Population Projections. You'll see on the x-axis of the chart that there is displayed the projected time frame by decades from 2020 until 2060, whereas the y-axis of the chart will display the growing aging population in the United States. The population is displayed in millions. So for example, by 2030, the projected older population will be 73.1 million, or 21% of the population. Then by 2040, the population will expand to 80.8 million, or 22% of the population. Further, by 2050, 85.7 million, or 22% of the population. And then 2060, 94.7 million, or 23% of the population. As we reflect further on the provided definition of a master athlete, note that the age of the athlete is significant due to the changes that are occurring in the human body as a result of the aging processes. Aging is a process that is going to affect every system of the human body. The body's systems are displayed on slide number 7 in the presentation. However, for today's presentation, I'm going to focus more specifically on the cardiopulmonary system. There exists an increased amount of diversity among the older aging population. These various factors that can influence aging, such as lifestyle and environmental factors, result in overall alterations to the human body. The body's cardiovascular system is not immune to these age-related physiological changes, and the associated clinical consequences that occur as a result. On slide 8 of the presentation, you can identify several of the major age-related changes in the cardiovascular system. This information presented is not inclusive for all age-related changes. As reported in box 3.3 out of the reference Guccion's Geriatric Physical Therapy, 4th edition, physiological changes include decline in maximum heart rate, a decline in VO2 max, stiffer, less compliant vascular tissues, loss of cells from the sinoatrial node that is commonly referred to as the heart's pacemaker, reduced contractility of vascular walls, as well as thickened basement membrane and capillary. The overarching clinical consequences of these changes in the cardiovascular tissues that are reported by the authors include the potential for a reduced aerobic workload, increased blood pressure, decreased ventricular filling time, and overall decreased cardiac output, a slower heart rate, a lower maximum heart rate, as well as reduced arteriovenous O2 uptake. So ultimately, these age-related cardiovascular changes can give rise to an increased risk of the development of cardiovascular disease, which has been defined by the American Heart Association, a nonprofit organization in the United States, as heart and blood vessel disease that includes numerous problems, such as a heart attack, stroke, failure, arrhythmias, as well as heart valve problems. Now, the Center for Disease Control, which is a science-based national public health agency in the United States, provides free access to the interactive online database referred to as Whiskers. Based on the most recent data, the leading cause of death for all ages, so older adults included, is heart disease at a whopping 26.9%. So on the chart, you can see our age group rankings that are going to be for this leading cause of death category, and it provides the specific population percentage. Although aging is inevitable, evidence exists to support the positive impact of physical activity in limiting the development and progression of diseases, such as cardiovascular disease that we previously mentioned. On the contrary to physical activity and leading an active life, a sedentary life can increase the rate of aging and decline. So sedentary behavior is defined as any behavior characterized by an energy expenditure of less than or equal to 1 metabolic equivalent. This could be in sitting, reclining, lying postures. A metabolic equivalent is defined as the amount of oxygen consumed while we're in these positions and is equal to 3.5 milliliters of oxygen per kilogram of body weight per minute. This is helpful to express energy costs during physical activities. And so as we're trying to combat this deleterious effects of being sedentary, which has become a global pandemic, the older adult population is encouraged to perform evidence-based recommendations for physical activity. So previous literature has recommended that older adults who are wanting to participate in athletic events, such as a master athlete, that they complete pre-participation screening, as well as be monitored by a multidisciplinary team. Now, in 2018, Physical Activity Guidelines Advisory Committee scientific report incorporated the following guidelines into the Physical Activity Guidelines for Americans, 2nd edition. They reported that for substantial health benefits, adults should perform at least 150 minutes per week to 300 minutes per week of moderate intensity, or 75 minutes to 150 minutes per week of vigorous intensity, aerobic physical activity, or an equivalent combination of moderate and vigorous intensity aerobic activity. Adults should also do muscle strengthening of moderate or greater intensity that's going to involve all major muscle groups on 2 or more days out of the week for those health benefits. They have found that additional benefits are gained by engaging in physical activity beyond the equivalent of 300 minutes of moderate intensity activity a week. And the 2018 guidelines also eliminated the previous requirement that aerobic activities must occur in bouts of 10 minutes of duration, as more recent evidence had revealed that the benefits can occur in less than 10-minute duration. Now, Master athletes, they're going to be unique as this group of athletes inspire many others to rise above these minimum recommendations and then achieve greatness through the process of training for and competing in athletic competitions. An example of a master athlete is pictured on slide number 11 of the presentation. And this is Rusty North. He is a 51-year-old Caucasian male. I had the pleasure of performing a face-to-face semi-structured interview with Rusty for approximately 2 hours on July 1st of 2023. The interview consisted of a series of questions that included, but are not limited to, those on this slide, such as what is your current title that you hold? And as documented on the previous slide, Rusty North is the SPF, or Southern Powerlifting Federation, World Powerlifting Champion. And questions such as, how did you achieve this title? What barriers, if any, did you have to face in order to accomplish your goal? Were any of those barriers health-related? What do you feel was your primary motivation? Did accomplishing your goal result in any additional challenges? Do you feel that age was a factor in any of the goal-related challenges? What are your future goals? And what advice do you have for others who are interested in pursuing a goal later in life? There were many key takeaways from this interview performed with Rusty North, but several of those include Rusty's current medical history, which is significant for an enlarged heart, atrial fibrillation, as well as cardiac ablation that is performed initially in 2018 and then again in 2021. Atrial fibrillation, just for background, has been defined as erratic quivering or twitching of the atrial muscle. And this can result from numerous causes. It's more common in older age. One of the results of atrial fibrillation is going to be a reduced cardiac output. Due to his medical history, Rusty sought counsel and management from a cardiologist, specifically a cardiologist who is a healthcare provider that recognizes that Rusty is determined and he was not going to give up on his goal, despite any challenges that he faced with his medical history. So through the interview, I was able to gather that working alongside his cardiologist as a team, Rusty was able to modify his lifestyle and then maintain progress towards achieving his ultimate goal. Examples of lifestyle modifications that Rusty performed included nutrition, such as reducing the amount of caffeine intake, stress management, use of a heart monitor and incorporation of a target heart rate into his exercise prescription. An example of a target heart rate being 135 beats per minute. More frequent rest breaks. And so Rusty described during his training, if he was running and he would reach his heart rate, needing to then rest and recover, and the importance of that. And also having advanced planning so that he was able to have a prolonged period of time to be able to achieve his goal due to these modifications that were necessary. Throughout the course of the interview, Rusty emphasized the importance of mastering the mundane. In other words, being disciplined in life, a character trait that Rusty has mastered beyond the realm of athletics, and one that he referred to as the blueprint to both his professional and personal life successes. In conclusion, at the interview, Rusty was asked to provide advice for others who are interested in pursuing a goal later in life. Rusty answered this question and he said, your age actually can be your biggest benefit. You realize how short life is, your maturity level, your ability to block out distractions, to recognize that you can't do it alone, to leave a lot of your ego at the door, to become more of a student. You build a network of people who are able to advise you before you make a bad decision or develop bad habits. Age makes it easy. In conclusion, I just want to thank you for your time and the opportunity to present at the 3rd International Conference on Cardiology. I'm hopeful that this presentation was able to raise awareness on the growing population of master athletes, as well as the importance of collaboration for healthcare providers who serve this inspiring group.
It's a retrospective study. So the background of the study was that atrial fibrillation is a common complication following coronary artery bypass grafting surgery. Postoperative atrial fibrillation was commonly developed on the second or third day after the operation. So the aim of our study was to determine the risk factors of new onset postoperative atrial fibrillation after on-pump coronary artery bypass grafting. The study were evaluated a total of 100 patients who underwent on-pump CABG. Patients were divided into two groups according to the development of new onset atrial fibrillation, as the AF group 50 number and non-AF group 50. Univariate and multivariate logistic regression analysis were performed to determine predictors of postoperative atrial fibrillation. Patients were assessed based on preoperative clinical features, pre- and intraoperative risk factors, and postoperative outcomes during the hospital stay. The inclusion criteria were that patients who were over 18 years old and undertook the operation. And exclusion criteria: patients were excluded from the study if they had a history of atrial fibrillation and had any valvular disorders. So we got that in older age was found to be an independent predictor of the development of atrial fibrillation in a multivariate analysis. Patients who developed atrial fibrillation were significantly older and had a higher CHA2DS2-VASc score. Admission glucose levels, serum potassium, and were identified as the risk factors of the development of postoperative atrial fibrillation. In multivariate analysis, P-wave duration more than 105 milliseconds, head score, and on-pump time more than 95 minutes were also associated with the development of this arrhythmia. In univariate analysis, the head score increased duration and amplitude of P-wave in the later second and increased the time of pulmonary bypass, were associated with postoperative atrial fibrillation. It was found that, so the conclusion was that it was found that the elderly age, higher glucose and serum potassium levels are independent predictors of postoperative atrial fibrillation after CABG. Head score more than 2, P-wave duration more than 105, and on-pump time more than 95 minutes were also associated with the postoperative fibrillation after CABG.
Professor Mohammed Hassan Aev. It's a great honor for us to welcome you on behalf of Azerbaijan Cardiology. Mr. Professor will read in Russian. You can address any question about his article to me after the webinar ends. Dear Professor.
Особенности клинического течения острого коронарного синдрома без подъема сегмента F нестабильная стенокардия и временно подъем.
Your voice is unclear. Excuse me.
У пациентов старших, работающих за горизонтными ксенобиотиками экологически неблагоприятных условиях.
To evaluate the clinical course of a non-ST segment elevation acute coronary syndrome with combined use of medical and mechanical revascularization in patients working in environmentally unfavorable condition contaminated with xenobiotics.
Резюме. Проверена эффективность комплексного применения гепарина антигипоксического, антихимического, антитоксического стомака, бета-1-блокатор, обзитан, пропранола, антигипоксический вазодилататор, степротектор, кардиотекс, мельдоном, антихимический, антигипоксический, биологически активный пищевой добавок паскар и кардиопротектор, ангиопротектор, блокатор рецептора ангиотензина 2 лазартана с механической реваскуляризацией ЧКВ и отдельно проводимой ЧКВ у пациентов, работающих в загрязненных ксенобиотиками экологически неблагоприятных условиях. Изучена экзотоксикоз, СМП, гемодинамика, кардиодинамика, электрическая нестабильность миокарда и клиническое течение ОКС. без подъема и временно подъемом пациента группы после выявления клинических симптомов нестабильности кардии или микроинфаркта для ускорения высасывания разжевали одну таблетку 150 на 325 мг аспирин и принимали одну таблетку изосорбитинитат кетет 2 раза в день. Далее, до стабилизации состояния пациента один раз в сутки, не разжевая после еды, принимали аспирин кардихет в указанной дозе. 15 мг стомах вводили внутривенно болезненно. Затем 15 мг препарата вводили в 150 мл 9% наствора натрия хлорида и вводили внутривенно по 20-25 капель в минуту 3 раза в сутки в течение 3 дней. Парапронолол обзидан в дозе 0,1% 5 мг вводили внутривенно болезненно в течение 5 минут. Потом по 0,02 мг килограмм в минуту вводили внутривенно по 20-25 капель в минуту 4 раза в течение 24 часа. Затем применяли пероральное применение препарата в дозе от 80 до 120 мг в сутки. Мельдониум кардиотекс 500 мг 5 мл вводили внутривенно болезненно 15 дней. Антигипоксический, антиишемический, метаболический препарат паспорт принимали по одной капсуле 2 раза в сутки. Блокатор рецептора ангиотензина 2 лазертан в дозе 12, 25, 50 мг в сутки проводили ЧКВ. Во второй группе только проводили ЧКВ. Всем пациентам вводили гепарин. Сначала 20 тысяч единиц внутривенно, одномоментно 10 тысяч единиц подкожно с последующим введением через каждые 6 часов в первые сутки. На второй, третий сутки 10 единиц, каждые через 8 часов, на четвертый, третий сутки 10 единиц. 1000 единиц каждые 12 часов на 6-й день, 10 тысяч единиц один раз в сутки с последующим назначением аспирин кардио один раз и клопидогрел 75 мг 2 раза в день. В обоих группах в крови определяли степень экантоксикоза СМП, биомаркеры некроза, креатинофосфатиназа, тропонин Т, тропонин И. С помощью эхокардиограммы и доплер-эхокардиограммы изучено значение конечного систолического объема КСО и конечного диастолического КДО, фракции выброса ФВ, ударный индекс УИ, сердечный индекс СИ, индекс нарушения локального сократимости НЛС левого желудочка. Выявлена желудочковая экстрасистола с помощью монитора системы Holter фирма Кардит, рестеноз с помощью повторной коронографии, ЭКГ по изменению расположения сегмента СТ и по повторной ангинозной боли. Определяли систолические и диастолические артериального давления, особенности клинического течения, острый коронарный синдром без подъема сегмента СТ, нестабильная стенокардия и СТ и временно подъемом сегмента СТ мелкоочаговый инфаркт миокарда. У пациентов, лечившихся гепарин, стомах, обзидан, кардиотек, васкар, лазартан и ЧКВ стабилизируют показатели центральной гемодинамики, снижает конечностистолический, конечно-диастолический объем, индекс нарушения локального сокращения, степень экантоксикоза СМП, улучшается систолические функции левого желудочка, повышается фракция выброса. Однако в этой группе у одного пациента на 3-й сутки регистрировалась острая сердечная недостаточность. В группе проведения только ЧКВ у 2 пациентов развивался рецидив нестабильной стенокардии, у 3 рестеноз, у 2 острой сердечной недостаточности и у 1 один пациент умер от развития прогрессирующего сердечного обширный инфаркт с зубцом Q. Полученные результаты показывают, что комплексное применение указанных препаратов ЧКВ позволяет получить прогностически положительный результат в отличие от отдельно проводимого ЧКВ при ОКС без подъема сегмента НСТ. Ключевые слова.
Just a moment. Summary, translation English. Purpose: to study the clinical complex use of heparin antitoxic, anti-ischemic, anti-hypoxic cytoprotector Cytomac, adrenoblocker, propranolol, Opsidan, antibiotic, vasodilator, cytoprotectors, Cardiotex, Meldonium, cardioprotector, angioprotector, blocker, angiotensin 2 receptors, BRE, 2, losartan, metabolic anti-ischemic predictor, MR, with mechanical revascularization and separately performed PCA in patients working in environmentally unfavorable conditions contaminated with xenobiotics, eco-endocytosis, hemodynamics, hemodynamics, electrical instability of the myocardium, and the clinical course of acute coronary syndrome were studied without ST elevation, unstable angina and temporary ST elevation, small focal myocardial infarction. To speed up absorption patient in both group after the onset of clinical symptom of NSAC, give 1 tablet of aspirin and top 1 tablet of isosorbitol dinitrate 2 times a day. Further determines the condition patients took aspirin and cardiac in the indicated dose once a day without chewing after meals. Of Cytomac was 15 milligram of Cytomac was administered intravenously. It's as above same 15 milligram of the drug was still treated in milligram of sodium chloride solution and intravenously at 20-25 drops per minute 3 times a day for 3 days. Propranolol Opsidan at a dose of 0.1% 5 milligram was administered intravenously as a bolus over 5 minutes. Then 0.02 milligram kilogram minutes was administered intravenously at 20-25 drops per minute. 4 times for 24 hours. The drug was administered orally at a dose of 18 to 1,000 to 1,020 milligrams per day. Meldonium Cardiotect 5,000 milligram, 5 milliliter was administered intravenously as a bolus for 15 days. The anti-hypoxic, anti-ischemic metabolic drug was taken on capsule 2 times a day. Losartan 5 milligram, 25 15 milligram per day. PCI was performed in the Tulen's group, only PCI. All patients were administered heparin first units intravenously and simultaneously units subcutaneously followed for by administration every 6 hours on the one-state day. On days 2, 3, 10,000 units every 8 hours. On 4, 5, 1,000 units every 20 hours on the third day. Units on the day, followed by aspirin cardio-ons and clopidogrel 2 times a day. In both groups, the degree of echotoxicosis, biomarkers of necrosis, creatine, phosphokinase, troponin T, troponin I were determined in the blood using echo and Doppler echocardiogram, where studied the values of the systolic volume and diastolic volume ejection fraction, stroke index, cardiac index, index of impaired local contractility of the LV, using repeated coronography, thrombosis, restenosis, segment, elevation, and repeat anginal pain. Ventricular extrasystoles were detected using the Holter system monitor. Stenosis using repeated coronary angiography. 4 changes in the location of the ST segment and repeated angina pain, systolic and diastolic blood pressure, and features of the clinical course of ACS were determined. BPST unstable angina result in patients of the first group treated with high doses of heparin, propranolol, obsidian, cytoma, cardiotex, meldonium, predictor, MR, Vascard, losartan, and PCI. Central hemodynamic parameters are stabilized, SAR, ADV in ALS, degree of echointoxicosis are resumed, LV systolic function improves, and AFE increases. However, in the group, acute heart failure was recorded in 1 patient on the 5th days. In the group that underwent PCI only, thrombosis developed in 2 patients on days 5 and 6 after stenting. Ventricular extrasystoles were detected in 3 patients polytopic PVS. In 2 early and 4 patients paired, relapse of HIV developed in 3 restenosis into AHF, and 1 patient died from progressive affair. The results obtained show that combined use of prescribed drug therapy with PCI allows one to obtain prognostically positive result, in contrast to separate PCI for AKS, BP, ST, and keywords. Any one question? Do you hear me? Any one question?
Aim of our study was to evaluate the connection between endothelial dysfunction, development of the mere adverse cardiovascular events after percutaneous coronary interventions. In our study, there were included 116 patients after elective PCI. 99 were men and 17 were women. The average age was 59. Patients were divided into 2 groups, with and without the development of MACE. In first group, there were 28 patients who developed MACE after PCI. These were return of angina, myocardial function, and cardiovascular death. In second group, there were 88 patients who did not experience the MACE during the follow-up period after the PCI. The comparative clinical characteristics of patients in the 2 groups are presented in this table. The average duration of patients in 2 groups of heart disease were small in both groups. 30 of coronary insufficiency before PCI also didn't differ significantly before the patients in the two groups. Clinical manifestation of class 1 to angina were observed in 4 patients in first group and 9 patients in the second group. Severe manifestations of coronary insufficiency were observed in the majority of patients in both groups. Submyocardial ischemia was established in 1 patient of first group and in the third patient of a second group, and then 18 patients in first group and 57 patients in second group suffered a history of myocardial infarction before PCI. The average number of myocardial infarctions suffered in 1 patient was similar in the 2 groups. In 2 groups, it was 0.8. In the second group, it was 0.9. Patients in 2 groups also didn't differ significantly in the prevalence of myocardial infarction. The number of patients with chronic heart failure was similar in both groups. The frequency of non-clinical risk factors such as smoking, arterial hypertension, diabetes, mellitus, physical inactivity, obesity, and family history of coronary artery disease in the group of patients who subsequently developed MACE was slightly higher, but the difference was with the group second didn't reach the statistical significance. According to the functional parameters of the left ventricle, there were left ventricle ejection fraction, ECV, and EDV. Before endovascular intervention in the patients of the 2 groups were comparable. So characteristics of coronary lesions that showed that the mean number of heavy nucleoside stenosis and occlusions didn't differ significantly between groups. The average number of stenosis in the first group in 1 patient was 2.2 in group 1 and 2.2 in group 2. The average number of occlusions per patient in group first group was 0.3 and in second group 0.32. The average number of affected coronary arteries in 1 patient was also similar in patients of the 2 groups and amounted to 1.9 and 1.9 in both groups. The average Scientex score index also didn't differ significantly between the 2 groups. The average number of the stented coronary arteries and the average number of stents installed per patient were similar in both groups. In group 1, on average 1.4 coronary arteries were stented per patient. In group 2, 1.4. The average number of installed stents per patient by type of implanted stents, the vast majority of patients in both groups didn't differ significantly. The majority of patients in both groups had new generation drug-elution stents implanted. This complete myocardial vasculation was performed in 17 patients in first group and 3 in second group. In complementary vasculation was were in 11 patients in first group and 25 in second group. About the laboratory diagnostics methods, we studied the dynamics of the plasma concentration of the soluble intracellular and adhesion molecule SVSM, troponin I, the activity of phonovolubrant factor, and natural anticoagulants such as antithrombin, protein C, and protein S before PCI and during different periods of observation. This period of observation were 1 day, 10 days, 1 month, 3 months, 6 months, and 1 year after PCI. So we got the average follow-up period for patients was 601 years in group 1 and 605 years in group 2. Analysis of long-term treatment results show that the development of PCI was mainly due to the development of standard stenosis in 13 patients, progression of atherosclerosis outside the stenting area in 17 patients, and the less often the development of late stent thrombosis in 5 patients. About the average duration of coronary artery disease and the average Scientex score didn't differ statistically between the groups. This so you can see the echo parameters of the patients before and after follow-up periods that didn't differ as the other parameters too. About the markers of endothelial function and parameters of the hemostatic system before and after PCI, depending on the development of a MACE after PCI. We got that from the two after 1 month and after 1 year. At the same time, there was a trend towards a gradual decrease in the concentration of series in patients who after with MACE, while in the second generally at a constant level. For factor for vulnerable activity before PCI didn't differ between the groups. Moreover, after PCI, patients with adverse cardiovascular events, almost throughout the observation period, it was higher than with a smooth long-term period. In both groups, a month after PCI, a trend toward a decrease in the activity of vulnerable was, and the concentration of, as we said, was higher in the first group, and about in the study group, the protein C activity was slightly lower until the third month of observation. First day it was after PCI, it was 53 areas, 104. At the second day, it was 63 OES, 101. 1 month after PCI, it was 80 OES, 100. The activity of protein S didn't differ between the groups during the entire observation period, except the first day after PCI, when it was higher in the first group. So 143, yes, 118. In this, in the first group, the antithrombin activity was lower than in second group within 6 months after PCI. When assessing the relationships between markers of endothelial damage, there have been revealed positive average correlation between the activity of antithrombin 3 and protein C, weak correlation between factor for the brand as the same concentration and protein A's activity, as well as between the activities of antithrombin 3 and protein S. So as you can see this in this graphic too. So according to the regression analysis within the Onivate model of factor activity, protein C and antithrombin and antithrombin S have appeared to be prognostically significant indicators of MACE development after PCI, and according to a multivariate model of factor vulnerable activity and antithrombin. So we can see this on this slide. This is the prognosis of adverse cardiovascular. When performing analysis, the area under the curve for factor vulnerable activity was 0.6. The cutoff point was 137%. For antithrombin activity, it was 0.6 and 82 respectively. So according to this, we can make the conclusions. The leading role in the development of MACE after PCI has the progress of endothelial dysfunction with the loss of thromboresistance perpetuated by the endothelium and increase the blood thrombogenic potential. The development of the inflammatory process in the vascular endothelium and endothelial dysfunction after PCI is manifested by increased expression of the adhesion molecule for the instruments after determining that patient with disease, there is decreased activity of natural anticoagulants, antithrombotics, and the further progression of decrease after PCI. More pronounced disorders determined in patients with MACE, which reflects increased procoagulant activity of the blood.
Dr. Kitbaya,
Sorry, I can't hear you.
do you have our voice?
Yes, yes.
A novel criterion for diagnosing metabolic obesity in normal weight Bangladeshi adults. Just a background before going to the main discussion. Now, some words about obesity. Obesity is a medical condition where excess body fat accumulates to such an extent that it can cause a negative impact on health, on human health. So it's the definition of the World Health Organization. Obesity induces adipocyte dysfunction with secretion of adipokines. This results in a cascade of reactions which trigger the atherogenic processes and insulin resistance, leading to a set of metabolic abnormalities. Now, how obesity is classified or assessed. We all know BMI is the most commonly used tool to classify obesity. However, BMI-based classification is no longer reliable because BMI does not take visceral fat distribution and adipocyte dysfunction into account. I'm sure you all know that BMI stands for body mass index. Now, the normal range of BMI for normal weight adults is from 18.5 kg per meter squared to 24.9 kg per meter squared. Some normal weight adults, I mean individuals who fall in this category, are found to have increased insulin resistance, atherogenic lipid profiles, and are more prone to suffer from type 2 diabetes mellitus and cardiovascular diseases. Some normal weight adults also are found to have these issues. Now, the term metabolic obesity has been coined to address these issues. Metabolic obesity can be defined as the presence of metabolic syndrome in an individual, irrespective of his or her BMI. This implies that a person can be metabolically obese in spite of having a normal BMI, that is normal body mass index, or being normal weight. According to the modified NCEP-APP3 criteria, NCEP stands for National Cholesterol Education Program, APP3 criteria, individuals are considered to have metabolic syndrome when they have at least 3 or more of the following criteria. So what are those? Firstly, this circumference can be more than or equal to 90 centimeters in case of males, and in case of females, this circumference can be more than or equal to 80 centimeters. Serum triglyceride level can be more than or equal to 1.7 millimoles per liter. If we say in milligram per dl, it can be more than or equal to 150 milligram per dl, or use of medication for this lipid abnormality. Serum high-density lipoprotein cholesterol, or HDL-C, is less than 1 millimole per liter, or less than 40 milligrams per dl in males, or less than 1.3 millimole per liter, or less than 50 milligrams per dl in case of females, or use of any medication for this lipid abnormality. Systolic blood pressure, more than or equal to 130 millimeter mercury, and diastolic blood pressure, more than or equal to 150, more than or equal to 55 millimeter mercury, or use of any antihypertensive drugs. And the final criteria, fasting blood glucose level, more than or equal to 5.6 millimoles per liter, or previously diagnosed type 2 diabetes mellitus. So these are the criteria. Field-based metabolic syndrome criteria have been the only, I repeat, only criteria or markers used for diagnosing metabolic obesity in adults. These give rise to an urge for exploring newer diagnostic markers. And since it's the only, till date, it was the only criteria. So researchers from all around the globe had an urge for exploring new diagnostic methods. Very recently, some studies or researchers have validated Visceral Adiposity Index, or VAI, to be a reliable and valuable indicator of visceral fat distribution and function. It also correlates well with the degree of insulin resistance. Now, what is VAI, or Visceral Adiposity Index? VAI, or Visceral Adiposity Index, is a simple gender-specific mathematical formula. So basically, it's a formula, nothing else, comprising both anthropometric and biochemical parameters. It does not require any complex investigation. Now, what are the anthropometric parameters? The anthropometric parameters are the individual BMI, or body mass index, and waist circumference. And what are the biochemical parameters? Biochemical parameters are the individual's serum triglyceride level and high density lipoprotein cholesterol levels. For males, you can see the formula for VAI or Y. It is a waist circumference divided by 39.68 plus 1.88 into BMI into triglyceride level divided by 1.03 into 1.31 divided by high density lipoprotein cholesterol level. For females, some changes in the values, but it's the same formula, some slight differences in the values. Here, waist circumference is expressed in centimeters, BMI in kg per meter square, and serum triglyceride levels in milligram per dl, and serum high density lipoprotein cholesterol in milligram per dl. Now, what were the objectives of this study? There is an overwhelming medical, social, and economic imperative to identify the individuals with metabolic obesity who may apparently seem to be risk-free due to their normal weight. In this study, the main objective of the study was to elucidate Visceral Adiposity Index, or VAI in short, as a novel criterion for diagnosing metabolic obesity in normal weight Bangladeshi adults, so that the susceptible subjects with higher risk of developing diabetes mellitus and cardiovascular diseases can be brought under early detection and intervention. My country is a very densely populated country, and we already have a huge burden of diabetic patients and patients suffering from cardiovascular diseases. What were the materials and methods used? It was a cross-sectional type of study. The study took place in the Department of Biochemistry and Molecular Biology in BSNMU. BSNMU stands for Bangabandhu Sheikh Mujib Medical University. It is the largest medical university of my country. The study took place quite a few years back, from March 2016 to February 2017. The study subjects were selected from attendants aged between 19 to 45 years from various outpatient departments of the medical university. Sample size was 100, not a very big sample size. Sampling technique was a non-probability sampling. Now the results and observation. What we got from the study, this figure shows the prevalence or the presence of metabolic syndrome among the study subjects. Among the males, we found that the total number of male participants were 53, and out of the 53 male participants, we saw that 42 participants were suffering from metabolic syndrome according to the metabolic syndrome criteria, and 21 of them were not suffering from metabolic syndrome. Among the female participants, the total number of female participants were 37. So out of the 37 female participants, 25 of them were found to be suffering from metabolic syndrome, obviously according to the metabolic syndrome criteria, and 12 were found to be normal. This is the receiver operating characteristic, or ROC curve, for Visceral Adiposity Index in male study. Yes. Just have a look at the curve. Okay, now this table describes the curve. So area under the ROC curve or receiver operating characteristic curve of visceral adiposity index in male subjects was found to be 0.9 with p-value of 0.000 and the optimal cutoff point was 244.1604. Performance of visceral adiposity index as criterion for diagnosing metabolic obesity in male study subjects. The performance was assessed in terms of sensitivity, specificity, positive predictive value, and negative predictive value. Sensitivity among the male study subjects was found to be 70.32%, specificity was found to be 77.88%, positive predictive value was found to be 70.92%, and negative predictive value was found to be 76.32%. Now, this is the figure showing receiver operating characteristic curve or ROC curve for the female study subjects. Just have a look at the curve, please. These are the tables. The first table shows area under the ROC curve value of VAI in female study subjects. Area under the curve for female study subjects was 0.9 with p-value of 0.000. And the optimal cutoff point was found to be 363.224. Performance of visceral adiposity index for diagnosing metabolic obesity in female study subjects was assessed in terms of sensitivity, specificity, positive predictive value, and negative predictive value. Sensitivity in case of female subjects was found to be 70.45%. Specificity was found to be 97.32%. Quite a high specificity value. Positive predictive value was found to be 86.96%, and negative predictive value was found to be 61.58%. Now, when we combine all the study subjects, I mean total, irrespective of male, female, the receiver operating characteristic curve for visceral adiposity index in all the study subjects. This is the raw curve. Let's have a look. And these are the tables, table 5 and table 6. They describe the curve, area under the curve value of visceral adiposity index in total study subjects was found to be 0.9 with p-value of 0.000. An optimal cutoff point was 312.891. And again, the performance of visceral adiposity index as criterion for diagnosing metabolic obesity in all the study subjects or total study subjects. The performance was assessed again in terms of sensitivity, specificity, positive predictive value, and negative predictive value. The sensitivity in total study subjects was found to be 92.05%, specificity 75%, positive predictive value 74.31%, and negative predictive value was -61%. Now, prevalence of metabolic obesity in total study subjects based on VAI or visceral adiposity index. The sample size is 100 again. Metabolic obesity was found to be present in 54% of the study subjects based on Y, and metabolic obesity was absent in 46% of the study subjects based on Y or visceral adiposity index. Let's come to the discussion. The receiver operating characteristic curve analysis was done to find the cutoff value of VAI. Area under the curve value of VAI was 0.9 with p-value 0.000, which indicates that Y or VAI or visceral adiposity index is good as diagnostic tool. Performance of VAI as a diagnostic criterion was assessed in terms of its sensitivity, specificity, positive predictive value, and negative predictive value. Sensitivity of Y in total study subjects is 92.05%. The specificity in total study subjects was found to be 75%. And the prevalence was, as I mentioned earlier, it was prevalence of metabolic obesity was 54%. And the prevalence of metabolic obesity based on metabolic syndrome criteria was 33%. So this is the main slide to focus on. Based on VAI or visceral adiposity index, the prevalence of metabolic obesity was 54%. And based on the metabolic syndrome criteria, the prevalence of metabolic obesity was found to be 33%. That means based on visceral adiposity index, the prevalence is close to almost double if we consider only the metabolic syndrome criteria. But when we consider visceral adiposity index, the prevalence nearly doubles. And the results of this study, I mean my study that was conducted in Bangladesh, this is supported by Lee. They conducted Lee et al. They conducted a similar study on the adults of South Korean population, which showed visceral adiposity index to be an accurate indicator of metabolic obesity. A similar study in Italy found visceral adiposity index to be a simple and clinically useful surrogate marker for insulin resistance in non-diabetic adults. This is also in favor of the results of my study. So in conclusion, we can say from this study, it can be concluded that visceral adiposity index is appropriate as an overall criterion for diagnosis of metabolic obesity in normal weight Bangladeshi adults. Also, these are the sources of references. Thank you all for your patient hearing.
Thank you, Dr. Tabassum. That was an excellent presentation.
Nearly similar. And also patients who have related comorbidity, illness, prolonged recovery time, and next, strengths and limitation of the study, strengths and limitation of the study, the strengths of the study. Okay, this study was done by a well-defined statistical model, and this should give a more appropriate result. And also as a strength, since there were a scarce of studies done in Western Ethiopia, this finding was used as input for other studies who wanted to research in this area and elsewhere. As a limitation, our findings were also subject to some limitations. There could be a chance that the duration of mild coronary symptoms may be overlooked by the individuals and the life. And also, the study could not identify other non-clinical predictors, since it is not reported in the treatment center. In general, this study found the factors that prolonged or shortened the recovery time for COVID-19 patients. The study concludes that severe COVID-19 patients were patients having other related diseases, older patients having symptoms as prognostic factors and prolonged recovery time. Therefore, healthcare providers and treatment centers should give a strict follow-up and priority to older patients, severe COVID-19 patients, and patients having other comorbid illness by focusing on respiratory difficulties and underlying pre-existing medical conditions to manage the disease severity and recover quickly. Here is the references that we have used for analysis. Thanks for your attention.
Thank you, Dr. Morrow, for your great presentation. Is there any question from participants?
Yes.
You're welcome.
Are you listening?
Yes, I'm listening.
Please, you hear me? Hello?
I am listening to you, yes. You can continue.
I'm sorry,
Mm-hmm.
it's okay. It's
okay, you can continue.
Dr. Lodimer, do you have any queries to Dr. Maru?
No, no.
Okay. Thank you, Dr. Maru. Dr. Ase, you can move on to the next presentation.
Okay.
Yes.
No, I would now like to invite Dr. I can't pronounce your family. I'm
Okay.
sorry, Dr. Volodymyr, to present the presentation.
Yes. Are you listening me?
Thank you.
Okay. Are you seeing my presentation or no?
No,
No?
your screen is invisible.
Yes. Just a moment, please. Just a moment.
Dr. Lodimer, can we share the slide for you?
I don't understand this mechanism of this show. I take my presentation to you chat, and in PowerPoint.
Can I share the slide for you, doctor? Can I display
Yes.
the PPT for you?
Yes, it's mine.
Okay, doctor. Okay.
If you want, if you help me, please. Oh, okay.
Is it visible, doctor?
Yes, it's my presentation. Okay. The ladies and gentlemen, I want to propose a theme of our investigation, a diagnosis and the surgical treatment of cardiac myxomas from Amosov National Institute of Cardiovascular Surgery of Academy of Medical Science, Ukraine, Kiev. Next slide, please. I don't keep this slide. Please, next slide, if you. The aim of the study was the presentation, okay. The aim of the study was the presentation of optimal tactics of diagnosis and methods of safe surgical treatment of cardiac myxomas. Next slide, please. On this slide, we can see quantity and structure of primary heart tumors in our institute from 1969 to 2023. 1,013 interventions were performed in heart tumors, from which heart myxomas was in 88.9%. Myxomas, benign primary heart tumors was in 4%, and malignant primary heart tumors was 6.9%. Next slide, please. On this slide, we can see heart myxomas localization because it's most large presentation tumors, primary heart tumors. And most of all was left atrium localization of cardiac myxomas, 87.9%. Right atrium was in 9%, and right and left ventricle 0.9% respectively. Multiplied localization of heart myxomas was in 1.3%. Next slide, please. The anatomical peculiarities of heart myxomas according to the echocardiography date was first, a porous character of neoplasm with uneven contour which are changing in the process of movement was in 74.7%. And the second, solid neoplasm with even smooth edges formed by a capsule was in 25.3%. Next slide, please. On this slide, we can see embolic complication cardiac myxomas in 69 patients, or 7.7% of all cardiac myxomas in our investigation. According to literature data, embolism can occur in up to 40% of cases of cardiac myxomas. And localization of embolic complication was Brian vessels 82.6%, vessels of the upper and lower extremities 14.5%, and coronary artery was embolism in 2.9%. Next slide, please. On this slide, we can see proportion of left atrial myxomas penetration into the left ventricle according to the echocardiography date. And first, most of all was mobile heart myxomas penetrating into the left ventricle cavity in 93.6%. Second, the less mobile heart myxomas, which occupies whole left atrium and penetrate into the mitral valve orifice, 0.9%. And non-viable heart myxomas, which are not penetrated in the left ventricle cavity, in 5.5%. Next slide, please. On this slide, we can see localization of left atrial myxomas to the intra-atrial septum. It is now our investigation. Operating date was 124 cases. Sorry. And lower third of intra-atrial septum was 53.2%. Middle third of intra-atrial septum was 36.3%, and upper third of intra-atrial septum was 10.5%. Next slide. And we propose the improved method of access to the right atrium and the intra-atrial septum for removing left atrial myxomas. We can see the gain of incis in near the right pulmonary vein on the upper third of intra-atrial septum. Next slide, please. And the frequency of damage of the base of left atrial myxomas with the application of the optimal methods of dissection of intra-atrial septum was in 97 operation. And first, the result without damage of the damage to the myxoma base was in 97.9%, and with damage of myxoma base was in 2.1%. Next slide, please. On this slide, we can see valvular lesions of cardiac myxomas in 75 patients, or 8.3% of all cardiac myxomas. And nature of valvular lesions was first, mitral valve damage 38.7%, aortic valve damage 2.7%, aortic and mitral valve damage 1.3%, insufficiency of tricuspid valve in right atrial myxoma 6%, involvement in the tumor process mitral and tricuspid valve 9.3% and 4%, and relative insufficiency of tricuspid valve was 30.6%. Next slide, please. On this slide, we can see features of macrostructure of myxoma in patients with mechanical valve damage in 22 cases. At first, there were large cluster-shaped myxomas without calcium inclusion in 3 cases. Second, the cluster-shaped myxomas with massive areas of fibrosis and calcinosis, 18 cases. And next, avoid myxomas immobile with calcification of the distal surface, 1 case. Next slide, please. And we have the problems of diagnosis in mitral valve injury in cardiac myxomas because in 22 patients with mitral valve lesions, 5 patients, or 22.7%, were not diagnosed valve lesions before the surgery. That is, cardiac myxomas precipitated in closing function of the mitral valve. In one case, there was rupture of the cord, which was not noticed during the revision of mitral valve. And we had a case of acute mitral regurgitation 1 month after the operation of cardiac myxomas removal. And emergency mitral valve replacement consequence. Next slide, please. In this slide, we can see valve operation in patients with cardiac myxomas or arsenal of surgical techniques. Reconstruction of the heart valves was, there were mitral valve annuloplasty according K, according bead, with support ring in 8%. Repair anterior leaflet of mitral valve with suturing and with patch was 13.3%. Repair rupture of the cord with suturing 4%. Repair posterior or both leaflets of mitral valve with suturing 5.3%. Repair of tricuspid valve with annual application about the Vega 40%. Replacement of mitral valve 16%. Replacement aortic valve replacement mitral and aortic valve replacement tricuspid valve 1.3% respectively. And separation tumor from mitral valve 9.3%. Next slide, please. On this slide, we can see mortality dynamics in heart myxomas removal in our institute. Last 22 years, we made more than 500 operations about heart myxomas removal with 0 mortality. Next slide, please. Conclusion. The success of cardiac myxomas removals largely depend on the sum of optimal diagnosis method and surgical techniques that ensure the safety of the operation. Second, mobility of cardiac myxomas is associated with the possibility of damage of the valvular system, which should be remembered during the surgical treatment. Third, the safest place of access into the left atrium cavity, so the atrial septum, is the upper third of the atrial septum, where the base of the cardiac myxomas is most rarely localized. Fourth, in the vast majority of cases, 81.8%, the cause of damage of valvular structure in the cardiac myxomas is the presence of severe fibrosis with a calcified surface of cardiac myxomas, which should be noted during the echocardiography. And fifth, safe removal of cardiac myxomas is ensured by prevention of fragmentation of cardiac myxomas, which is very important stage of access through the atrium septum. Thank you very much for your attention.
Thank you so much. Any question? Is there any question from dear participants? Okay, that